Good morning to everyone. Just from the direction of the course, I thank you for your time, and we are waiting just for 1 minute to start. I will call for Dr. Amy Tyberg from New York, who was giving her talk about EUS-guided drainage for pancreatic fluid collection. Good morning, Amy.
Good morning. Should I start, or are we?
I don't know. We can wait just for 1 minute from Paolo. He told me 1 minute, so I was quite in a hurry.
Okay.
Well, we can start.
Okay, all right. Thank you so much. Thank you to the course directors for having me. I'm very excited to be here. The first time I came to this course 5 years ago was actually my first international course doing live cases on camera, so it will always hold a special place for me. And I'm very excited today to be talking about EUS-guided pancreatic fluid collection drainage. So we all know that pancreatitis is a worldwide problem and expected to get increasingly worse in the near future due to increasing rates of obesity and gallstones, and anywhere from 5 to 15% of patients with acute pancreatitis will develop a pancreatic fluid collection. And when we talk about pancreatic fluid collections, we use the Atlanta classification system that was revised in 2008, which basically divides pancreatic fluid collections based on their chronicity from time of onset after the acute pancreatitis, as well as if there is a presence of necrosis within the collection. So we have our acute peripancreatic fluid collections. These are the poorly organized acute collections that do not contain any necrosis, that will either get better on their own or evolve into pseudocysts, which have a nice formed wall, but just fluid without the presence of necrosis. Or we have our post-necrotic pancreatic fluid collections, which again are poorly organized, but necrotic collections that again either resolve over time or form into what we call walled-off pancreatic necrosis. But just because there is the presence of a fluid collection does not necessarily mean that it needs to be drained, and the really only collections that require drainage are those that are symptomatic or infected. So these are some of the indications for pancreatic fluid collection drainage: the presence of symptoms, most commonly abdominal pain, early satiety if it's compression of the stomach, nausea, vomiting, biliary obstruction causing jaundice, or the presence of complications, the biggest one we think of being infection, gastric outlet obstruction, biliary obstruction, fistulization. And it's important to note that size alone is not a sole indication for intervention. It really needs to be symptomatic or causing complications. So when we talk about drainage of pancreatic fluid collections, there's really 3 approaches that can be undertaken: the endoscopic approach, there's also percutaneous approaches, as well as surgical drainage. And when we talk about endoscopic drainage, we're really talking about EUS-guided endoscopic drainage. There was a time when this was done without EUS, but there's been a plethora of studies that have really shown that EUS adds a significant benefit to draining these procedures, and I don't think there's anyone nowadays that is draining pancreatic fluid collections without using EUS to help classify the collection, avoid any vessels. Percutaneous drainage is effective, but when you look at studies comparing percutaneous to endoscopic drainage, this is just one of many. This one is a relatively large, 81 patients retrospective, and it showed that there was equal technical success, adverse events, but patients that had endoscopic drainage had decreased rates of reinterventions, shorter hospital stays, and a decreased number of follow-up abdominal imaging studies. Similarly, this is an old paper, but still important when looking at endoscopic versus surgical cyst gastrostomy for pancreatic pseudocysts, and this was 40 patients, but a randomized trial, again showing similar technical success and complication rates, but the endoscopic therapy had Some benefits including shorter hospital stay, lower overall costs, and better mental health and physical health component scores among patients who underwent drainage. So based on that, I think we can say that endoscopic therapy is the preferred choice. But with the caveat that there are factors to consider. You need to consider the location of the collection. If it's in close proximity to the GI lumen, obviously if the collection is far away from the GI lumen, endoscopic drainage may not be an option, and you may need to choose an alternative approach. Also important to consider the maturity of the collection, if there's a presence of a formed wall, as well as the available expertise at the center. But since this is a EUS course, we're going to focus mainly on endoscopic drainage. So once we have decided to drain a fluid collection, the first question to really ask yourself is, what type of stent should I use? And there's a variety of options. We've seen actually 2 different options already in the live cases yesterday. We have plastic stents. You can use the fully covered biliary self-expanding stents. Even there's been case reports of using esophageal fully covered stents for these collections. And now I think probably the most common stent that's used is the lumen-opposing metal stent. And when you're deciding what type of stent to place, there's a bunch of factors to consider, including the type of collection. Is it a pseudocyst, or is there presence of necrosis? Is there presence of infection? If so, you might want to choose a larger diameter stent in those cases. The size of the collection, smaller collection is going to be harder to accommodate. A bigger stent, like a lumen-opposing stent. Again, the distance between the pseudocyst or the wall-enough necrosis and the lumen, keeping in mind that the diameter of the lumen-opposing metal stents is only 1 or 1.5 centimeters, so you need to be relatively close to the GI lumen, as well as the expected duration that the stent is anticipated to be in place. But no matter what stent you use, the approach is relatively the same. It involves the same steps. You're going to visualize the fluid collection using endoscopic ultrasound, access the collection, create a fistulous tract, and then deploy a decompressing stent. And when you, depending on the type of stent, you sometimes combine all these steps with one device, but the process still remains the same. So this is a video. If someone can start it. Okay, so we've already seen several of these procedures during the course. This is using a lumen-opposing metal stent. You can see that accessing the collection and creating the fistulous tract is done in one step here. Here's the internal flange being deployed within the collection. It's then pulled back to retract the cyst against the wall of in this case, the stomach, and then the proximal flange is deployed in the GI lumen. You can see at the bottom left of the screen on the endoscopic view. It's always very satisfying when you get a big flush of drainage afterwards, like we saw in one of the cases yesterday. So sometimes endoscopic drainage is not enough for collections that have the presence of necrosis as well, and they require not only drainage, but also direct endoscopic necrosectomy, where the endoscope is actually advanced into the collection for mechanical debridement. And this can either be done by dilating a fistulous tract, or in the case of lumen-opposing metal stents, you can put the scope directly through the stent into the collection for debridement. However, this is not for the uncommitted. It often requires multiple sessions every 48 hours. These patients are generally inpatient while they're undergoing these sessions, and there is the potential for significant complications, even in the most experienced hands, so it's very important to have a multidisciplinary approach available when embarking on necrosectomy. And there's a couple landmark papers that I just want to highlight. This is the New England Journal of Medicine paper from 2010 looking at the step-up approach, basically starting minimally invasive and working to more invasive as needed versus going directly to a more invasive approach. And you can see that in this study there was less major complications or death in the minimally invasive arm, less long-term complications, and better healthcare resource utilization, lower overall costs, so certainly advantage with the minimally invasive approach. This, again, a little bit older paper, but very important study looking at endoscopic versus surgical necrosectomy for necrotizing pancreatitis. And again, in the endoscopic group, less major complications, overall significant benefits. And now, just a couple years ago, we have a randomized single-center trial, 66 patients of minimally invasive surgery versus endoscopic approach. And while there was no mortality difference between the groups, the endoscopic arm had significantly lower fistula rates, fewer complications, and better quality of life scores after drainage. So again, endoscopic management, when feasible, seems to be the preferred choice. And I will just let this play for a little bit because I think I'm running out of time, but this is what necrosectomy can look like. You can see lots of necrosis on the superior wall here. And the scope has gone into the collection, just manually debriding, taking this necrosis and pulling it out through the stent into the gastric lumen. Everyone has their favorite necrosectomy tool, I like to say. This case, it's a Rothnet. I tend to use a trapezoid basket that's usually used to collect stones on ERCP or a snare, but lots of options. All right, just a few additional considerations. Think about enteral feeding when you're draining pancreatic fluid collections, especially for patients that have significant pain. It's been clearly shown that post-pyloric enteral feeding is superior to TPN in these patients. And it's important to remember the pancreatic duct. There is certainly benefit to making sure that there's not a pancreatic duct leak, either with pancreatic duct exploration, ERCP, or with secretin MRCP. And this, I'll just end with, this is the treatment algorithm that we use for patients with pancreatic fluid collections in New Jersey. You can see, depending on the type of collection, whether it's poorly organized, whether it's a pseudocyst, whether it's pancreatic necrosis, determines the type of intervention that we perform. And I will stop there. Hopefully I made it. Yeah, okay, thank you so much. Yeah.
I think that could be easier to drain a collection rather than talk about pancreatic fluid collection drainage in 10 minutes,
faster, I think, yes.
Right. We sincerely thank you. We call Professor Michel Calais for the next talk about US-guided biliary drainage. Thank you once again, Amy, for...
Thank you for having me. It's obviously an honor to be back in Milan with so many pristine faculty. And I'm going to try also to stick to 10 minutes. So I promised Paolo that I'm going to stick to the point. All right. So as you know, US-guided biliary drainage is a very important tool that we've been using since there are at least 3 to 5% of biliary obstruction that cannot be managed by conventional ERCP, either due to a problem at the level of the ampulla, altered anatomy, gastric outlet obstruction. So, as you know, PTC has been used, but PTC slowly has been replaced by US-guided biliary drainage. This is obviously the right institution to discuss about replacement of PTC by US-guided BD. 2001 is when Mark Giovannini described the very first US-guided biliary drainage. Actually, the same year, he also described the very first hepatogastrostomy. Since then, there have been a gazillion of studies showing the efficacy and safety of US-guided biliary drainage. We have this very nice summary from Wang with 42 studies encompassing 1,200 patients with a technical success of 95%, a clinical success of 92%, and at that time, adverse event rate of 23.3%. This is before, the concept of using metal stents when we use US-guided biliary drainage. So there's obviously now a trend of doing this. There's always two approaches, the intrahepatic and the extrahepatic approach, and each approach now slowly has been managed with more and more skill sets and using more and more metal stent, whether it's lumina-posing metal stent for the extrahepatic or a long metal stent covered with anti-migratory system for the intrahepatic. So this is one of those systematic review meta-analysis that we did, looking back at 10 studies with 434 patients. And really, the most important concept is every patient needs to be individualized in terms of treatment. There are some data showing that choledochostomy can be associated with a little bit more adverse event. It seems that the liver is a little bit more forgiving when you're doing hepatogastrostomy. It's very hard to have problems unless you encounter a very difficult anatomy. So the steps are the same of any cell ligand procedure. You have to visualize your target. You need to get the access. You have to place a wire. You have to create a fistula and then place in a stent. I'm not going to talk about study comparing EUS-guided to percutaneous drainage. I mean, we have established this. I'm going to go straight into how do we compare it to ERCP. There are 3 important randomized controlled trials that look at the efficacy and safety of comparing ERCP to EUS-guided biliary drainage. And you can see actually that they pretty much have the same safety and efficacy. What is interesting, there's even a trend for being actually safer when you're using the EUS-guided biliary drainage. And when you think about it, you're basically decreasing the chance of bleeding, and you're obviously decreasing the chance of post-ERCP pancreatitis. And that is a very important concept. Like for the first time, we start now thinking about doing EUS-guided biliary drainage as a first approach. And this institution here in Milan did one of the first randomized controlled trial in patients with malignancies, where they straight up offered in one group EUS-guided biliary drainage compared to ERCP. And it's actually a concept that has been gaining more and more momentum in our field. So the extrahepatic approach, this is the old-fashioned extrahepatic approach where you're trying to place a stent transpapillarily. Many people will now shift directly to hepatogastrostomy, especially if you have altered anatomy. You gain access here on the left hepatic duct. You inject, you get your roadmap. You're going to place a wire. We really like the VisiGlide. There was a debate yesterday about 25 versus 35. I still like the 35s. It gives us much more leverage. And here, since we don't have the 6 French cystotome, what we typically do, we use the Hurricane. It's a very pointy balloon, as you know, that allows you to literally get through the capsule of the liver. And we're gonna advance the balloon all the way above the obstruction here, inflate the balloon, and we're gonna be playing with the wire. Those are all ERCP maneuver. We're gonna dilate the stricture. Once the stricture is dilated and we have a decent access into the small bowel, we're gonna exchange this Hurricane balloon for a fully covered self-expanding metal stent, which we're gonna place in an antegrade fashion. Here we are crossing the obstruction and advancing the stent across the obstruction into the small bowel. So this will be the classical antegrade approach using an intrahepatic access. Many cases we will now switch to hepatogastrostomy. We still place clips if we have the impression that the creation of the hepatogastrostomy can lead to bleeding. And this is the extrahepatic approach. So you see the landmark here, finding the dilated common bile duct. Here is the access with a transduodenal injection. And then hot access, 8 millimeters, is being placed. There's actually a video that was shared to me by my friend Alberto Larghi, and he was bragging that this took him literally 12 minutes. So it shows you how fast those procedures can be done in expert hands. And here we have the access with complete decompression of the biliary tree through the bulb. Learning curve, it takes between 32 to 40 cases to be comfortable in EUS-guided biliary drainage, assuming that somebody has been trained in EUS-guided procedure and has been performing pseudocyst drainage. Very important to remember that the idea now, since EUS-guided biliary drainage is gaining momentum, can we actually send those patients to surgery? This is a very important study that we did actually with the team of Milan. so other friends internationally, where we compare people getting conventional ERCP prior to surgery to getting EUS-guided biliary drainage prior to surgery. And it was a very interesting study because all the data that we have point that EUS-guided BD appear non-inferior and maybe superior to conventional ERCP for biliary drainage prior to hepatobiliary surgery. So we have to talk to our surgeon to convince them that we don't actually need to do conventional ERCP to decompress those patients. We can now offer them EUS-guided BD and still have a very safe surgery. So we don't have time to go over different techniques used to get to the bile duct when you have altered anatomy. Edge is one of them, creation of a gastrogenostomy is another one. But the idea is therapeutic EUS has completely changed the field of how we offer biliary decompression. So as a summary, ERCP remained the standard of care approach for biliary decompression. It's not feasible in all patients. There is clearly a risk of post-ERCP pancreatitis. EUS-BD is already an established alternative to ERCP, and really now there's a trend to actually offer it as a first intention biliary drainage, even in patients that may undergo later a curative resection. The choice of technique depends on access to the small bowel and to the papilla, and whether the obstruction is intra or extrahepatic. Thank you so much for attention, and as I said, it's always a pleasure to be back in this beautiful place. Did I make it?
Thank you, Professor Kali. You get really fast and complete. And it was my pleasure to invite Professor Di Matteo from Rome, talking about EOS-guided anastomosis.
Hello to everyone. Thank you for the kind invitation at this outstanding event. I would like to say that I feel a little bit uncomfortable speaking about a topic with these pioneers, Amy, Michael, because they trust in this approach in 2015, probably 2016. So we are 10 years more. So after yesterday, I changed my presentation because I would like to recommend what ESG says about this procedure, EOS-guided gastrointestinal anastomosis. They say that we need a multidisciplinary discussion for patients being considered for EOS-GEE and careful evaluation for adverse events after the procedure. You must be skilled in therapeutic EOS, but in EOS, in endoscopy. So, which are the procedures? EOS gastroenteral anastomosis, gastrogastroanastomosis, that is the base of EOS-guided transgastric ERCP, that tears down the enteroscopic assisted ERCP and laparoscopic assisted ERCP. EOS-guided gastrointestinal anastomosis for afferent loop syndrome, and last, probably not least, EOS-guided colon enterostomy. So this is for, I don't know the audience, there are experts, but also a young person. The enteroscopic assisted ERCP has a low rate of success. Why? For this reason, and because we use instrument with a small channel. That's why the force that we apply on the device are not transmitted in the biliary tree. So gastric outlet obstruction and afferent loop syndrome or colonic obstruction have a significant effect on patient morbidity and quality of life. That's why surgical gastrojejunostomy is, or probably have been, a gold standard. Why? The procedure has a prolonged recovery times, delaying chemotherapy for malignancy-related obstruction, delay gastric emptying and gastroparesis after surgery, and procedure-associated costs are enough. That's why EOS-GE increased the role. which are the difference compared to surgery? Low morbidity, low mortality, shorter procedure time, potentially reduced cost. And what about enteral stent? Lower recurrence, lower recurrence, no risk of obstruction cause tissue ingrow or overgrow, marked reduction in reinterventional rates, longer stent life. Which are the procedure? Direct over the guide wire, wireless endoscopic simplified technique, or assisted gastrojejunostomy technique with a balloon, a biliary balloon, or double balloon, or a guiding catheter, or a nose biliary catheter. And the last one, rendezvous US guide wire technique or retrograde deployment. But what the study says, retrospective cohort study says that the first one, the West procedure, has a higher technical success and lower adverse events. So what we can suggest, CT scan before, always, with a transient and coronal view. Not inject relaxant drugs before visualize the jejunal loop. Which are the procedure more cumbersome? That one that have to pass the stenosis of the fourth portion of duodenum and the presence of ascites. This is not a major contraindication, but a relative contraindication. So this is a case of course, a palliation that we perform with a Spaxus stent. We passed by the stenosis with a catering wire, high-breast catheter for ESCP. We inject, filled up the loop. We target the loop with a good pathway, and then we release the stent. It's a different stent, different shape of the stent, as you can see, compared to the Axios 1. This is the distal flange, and then the proximal flange. So we do not dilate usually the stent. What are the contraindications for USGI? Should not be performed in the presence of a significant malignant or refractory ascites or diffuse malignant infiltration of the gastric ball or extensive peritoneal carcinomatosis. But what about in benign GO? ESG suggests to reserve this procedure for patients who are poor surgical candidates with a refractory benign gastric outlet obstruction, and recommend that upon resolution of the cause of the benign GO, the lumen apposite metal stent should be removed. What about in an afferent loop syndrome? ESG recommend to consider this procedure in the management of afferent loop syndrome, especially in the setting of malignancy or in poor surgical candidates. This is an example. It's easy to perform when you got a PTD, of course, or stent, previous stent, or when there's a dilation of afferent loop. It's more complicated if you have to fill up this loop with water. But what about US-guided gastrogastostomy? We saw yesterday an intriguing case in famous end. This is a procedure first described by Kedia in 2015. It's an anastomosis between the gastric pouch and the remnant stomach. This is a case of a previous gastric bypass for obesity, cholecystectomy, and then a damage of a sliding branch of the biliary 3. It was very slim. We filled up the gastric pouch. Then the first step is the deployment of these lamps. Then we dilate. It depends from the condition of the patient. Of course, if you have to be in a hurry, you have to use immediately this anastomosis. Usually we prefer to wait for a while, for a day, but this was a damage, sorry. And this was the final image. But another interesting application could be this US guide color enter anastomosis. There are few case reports in literature, one from the group of Milan, US guided iliac ascending colon anastomosis as an alternative to surgical stoma. The other one was previous one, 2080, color enter anastomosis as a salvage drainage procedure in an high surgical risk patient with small bowel obstruction. These are two examples recently performed. This is important to have a reprisal of the abdomen with the coronal section. This is a solitary encasement of a intestinal jejunal loop, terminal jejunal iliac loop. We have been lucky because not always it's possible to reach the right column with a linear one. So you can easily see the dilation of the last part of the hilum and the stent at the end. And this is another patient with an encasement of the right side of the colon. So we decided to conjunction this middle part of hilum and the left column. But there was a severe diverticular disease, so we used the colonscope and an overtube by Lumen D to carry on the probe. And was an interesting use because we can use the balloon at the end of the overtube. So the technical approach is completely different. Probably in this case you can imagine that you don't know exactly the shape of the column above. So the guide wire probably can help you to describe this alpha loop. This is probably not colon. And we take a puncture. Usually you cannot take a puncture in this field. But the patient was okay. So my closure is that this procedure is currently only performed at a tertiary referral center by operators with expertise in interventional US and endoscopy. While this approach quickly demonstrates their role in clinical care, various knowledge gaps persist. Our current unresolved questions are amenable to randomized controlled trials, but relative rarity of the disease, a lack of a standardized comparator, allow us to use the retrospective study. Thank you.
Thanks, Francesco, and I once again thank all the speakers for this brilliant session of presentation about US-guided intervention. And before giving the line to Professor Arcidiacono, we are ready to show you a brief video of this day, and then I think we are ready for the first live session of today. Thank you all.
Good morning. Can you hear me? Welcome, everybody.
Yes, Paolo. Good morning.
Thank you, Andrea. Good morning. So thanks to our speakers for being so strictly appointed to the time. So we are ready to start this second day of live demo from Milan and from all the other connections that we have organized for these 2 days. And talking about these connections, we are ready to connect with the University of Hong Kong, with Professor Anthony Teo, who is waiting for us. Good morning, Anthony. Can you hear me?
Hello, Paolo.
Hello, hello. Welcome to US, and thank you for being with us. I think that you are ready to start, so please go ahead and present your first case. Thank you very much again.
So thank you, Paolo, for having us. It's a great honor for us to be participating in the Euro-US this year. So I have my colleague, Dr. Locke. He's a consultant in pancreobiliary surgery. So he'll be presenting with us the case.
Sure. We have a 64-year-old gentleman here with a metastatic ciliary head of pancreas, complicated with duodenal and biliary obstruction. So he presented with biliary obstruction with an ERCP performed in the district hospital, noted to have a distal CVD structure, plastic stent inserted. Subsequent workup shows a liver metastasis. And the patient was complicated with a blood stent. Upon the attempt to revise the plastic stent, noted to have a disease progression with duodenal obstruction. And therefore, a left PTBD was inserted. And duodenal stenting was performed, which covered the papilla. And here, now the patient is having a left PTBD with a daily output of about 1 liter. So we invited Professor Teo to attempt HGS so as to convert the biliary drainage into internal drainage. And here shows the endoscopic procedure.
So can you see any X-ray or US images? Can you guys see the X-ray and US images? Okay, can we have the X-ray image as large? X-ray image as large. Okay, so this is the cholangiogram. So we injected some contrast just to give us a roadmap. So you can see he has many stents inside. So he has a duodenal stent. He has a biliary plastic stent that was inserted previously, and now it's blocked. And he has a PTBD. So the plan is to internalize with a HGS. So we don't want to insert any more stents transpapillary because all that area is very clustered. The tumor is advancing, and so most likely we'll block again. So on US, can you change back to US? So this is a US view. So you can see quite a dilated duct. This is the segment 3 duct, and it's up to around 8 millimeters. Okay, so can you trace with the... So this is the segment 3 duct, which goes down and then joins the segment 2 into the left, into the CHD. So it's very dilated. And then the segment 2 duct is probably around here, branching up. So usually we would want to perform HGS in the segment 3 duct. So this would be around here where I would puncture. And we will be inserting a new stent, which is the Spexis HGS stent. Can we have the room view large, please? Room view large. So you can see this is the Spexis HGS stent. It's from Taiwan. So the head in the stomach side is kind of like the Spexis stent design. So, okay, so we will start now. So you can see my needle coming from the US view. So I'm going to puncture with the needle first, and then you can see my needle should be inside the bile duct already. So I inject some contrast. Okay, and I have some saline. So you can see the left PTBD is sort of in the same duct. So the plan is to insert the wire, dilate with cystotome, and then pull out the PTBD and then insert the stent.
Hello, can you hear me, Anthony?
Hi.
Hello, I'm Andrada. Nice to see you.
Hi.
Please tell us which should be the length between the bile duct that you have punctured and the hepatic capsule.
Yeah, so usually we want to have some different parenchyma in between. So for this patient, it's around 1.6 centimeters. So right here, right now, I'm trying to manipulate my wire into the main CBD. Okay, so you can see it's going down now. So I think this is a good position. What do you guys think?
Professor Tio, could we have the X-ray image larger, please?
X-ray image large, please. Exchange. So my wire is already, wait. Okay, thank you. And my wire is already in the CBD. Okay, so we are going to exchange. And during exchange, I always try to keep the wire under my ear's view. Okay, thank you. And then I'm using the cystotome. It's a 6-strand cystotome. I think some centers do use a blunt dilator, such as a REN dilator or a 4 millimeter hurricane balloon.
Anthony and Paolo, do you use this? Hi, do you use the cystotome because the new stent that you are presenting doesn't have an electrified tip?
Yeah, this new stent does not have an electrified tip. So there's also a new stent which has an electrified tube.
Yeah, we have seen presented yesterday by Sandeep during the same procedure, electrified hot jobber. So because this is from the same company, I was thinking about the possibility to have these hot spaxus for the hepatocogastro.
Exactly. So I think it's not good to have too many new things in the same device at the same time.
We can't hear you. We can't hear you, Anthony. Sorry.
So I think for the company, they don't want too many new things in the same device. So I think for the
can you please ask your technicians to set up your microphone because we lose you. Okay, now is okay. Now we can hear you. Yes.
Hello. Yes, I think because the new stent, maybe the company doesn't want to have too many new things on the same device. So for the geoball, we are very accustomed to it. So they introduced a new delivery system for that. And for this stent, it's mainly just stent design. So they stick with the old delivery system. So anyway, I'm ready with the cystotome. So I'm going to go in. Pay attention on wire, please. Okay. Attention on wire, please. In already, okay, just a little. So the cystotome is in the bile duct now, okay. So I'm gonna ask Dr. Locke to remove the PTBD because it's in our way. And can we open the stent now?
And Professor Tio, good morning. Which length of the stent do you choose for this drainage?
So for this size of the duct, it's around 8 millimeters. So we are using an 8 millimeters times 8 centimeter stent. So because the patient is in a prone position, so it's a little bit difficult.
Anthony.
Hi.
How are you, Anthony?
Good. Long time no see.
Case. Yeah, beautiful case. When do you remove that perk drain?
We are removing it now because it's in the way of the extra stent. Yeah. So it's a bit in an awkward position. So Dr. Luke is taking some time.
Don't worry, take your time. Anthony, the idea of this new stent is to be able to have less stent in the stomach. Is this true?
Less stent and then lower risk of migration outside the stomach, yes.
Okay.
All right, can we pull back some more, the PDBD? Okay, so you can see the PDBD tube is being pulled back. Okay. Okay, so let's exchange. Okay, cystotome. Cái sáu mình linh động. Khởi cái sáu. Khởi cái sáu. Thank you. We will pull back to the front. The hand is sort of in the way. Okay, thank you. All right, so we're going to insert the stent now. Thank you. So I think for this stent, the delivery system, the deployment method is similar to what we are used to. So basically insert the stent deeply and then deploy part of it in the bile duct and then part of it in the channel. So the distal 1/3 is similar to geoball, which is an uncovered stent.
So you have the same markers as the Jobor. So you have the marker for the 3 centimeters and the other marker. Okay.
Yeah,
great.
correct.
Great.
Okay. So I think you can see the the 2 wires where there's a crossing, there's the uncovered portion. So I think we are pretty deep inside the bile duct. So I'll probably open around here. Okay, can we open? What? Yeah. Open? Yeah, open. I'm going to deploy the entire stent within the scope. By the way, I'm using the new ME3 echoendoscope. So it is the newest device from Olympus. So all the stent has been deployed now. So I'm going to change to endoscopic view. All right, I'm going to push out the stent slightly. So you can see the stent around around this position, 12 o'clock. And I'm pushing the stent now. And then the remaining of the stent open completely. Okay. All right. Okay. So that's the head of the HGS. So can we have the Y? So I'm going to do a check cholangiogram. Cystotome, please.
Anthony, what about the diameter of the distal flange of this stent?
This diameter is, I think, 1.6.
That's great. It looks great, absolutely.
Yeah, I think we could have it even shorter, but we are so used to deploying these long HGS stents, so it might take some time for us to change our habit.
Yes, but it's very nice because if it's effective in anti-migration, probably you could also put shorter stent at now.
Yes, correct. Completely agree.
At the moment, do you have only this measure, so 8 millimeters, 8 centimeters, or do you have others?
There's a 10 millimeters as well, and then I think 8 is the current shortest length, but of course we can make shorter ones in the future. Yeah. Contrast. All right. Okay, so this is the cholangiogram, so there's no leak. Okay, I'm gonna pull everything out, so.
So great. Absolutely great procedure, Anthony.
Great, thank you.
Congratulations to the team. And we are going to connect again in a few minutes. Okay, thank you very much, Anthony.
Okay, bye-bye.
Very nice work. Thank you very much.
See you later.
So,
thank you.
We are back in Milan. Good morning, everybody, again, so we can present the first case of today here in Milan.
First case is a 78-year-old female with not a relevant family history and 3 past endoscopic resections for low-grade urothelial cancer. She, for a recent onset of jaundice, she performed laboratory tests with increased cholestasis and bilirubin levels without inflammatory markers and a really high CA 9.9 levels. Body CT scan, it showed multiple metastases at liver, 4th and 5th segment. The largest is 4 centimeters at the liver hilum with the upstream ectasia of the intrahepatic biliary tree. The gallbladder is with a stone and with wall thickening infundibulum. The scheduled procedure is EUS with the fine needle aspiration of biopsy and possible ERCP depending on the fine needle aspiration. Operators are Professor Petroni and Professor Savtoiu for EUS, and for ERCP, Professor Mariani.
Professor. Maria Chiara, can you hear me?
Yes, can you hear me?
I think that we have some problems with the audio, but we are managing. Okay.
Can you hear me now?
Talk louder.
Okay.
But we can hear you. Good morning. Good morning to Adrian.
Good morning to everybody. Welcome back in Milano. We can see immediately the probe is in the upper part of the stomach. And we can see the dilation of the intrahepatic duct. So starting from here, I try to follow the portal vein. Yes. Adrian is helping me. And below the portal vein, we can see something, some tissue, some hypoechoic tissue, yes. and many pathologic lymph node around the hepatic hilum. So just have a look to the body and tail of the pancreas. We have the confluence here. PD is not dilated. I think that when we have a suspicious lesion of the proximal part of the common bile duct, the best position to staging the lesion is the bulb. So now I'm approaching the bulb. I'm working with the linear EUS scope from Pentax, the J10 line. So now the probe is in the bulb, and we can see again the portal vein. And now I try to release the tip and look for the common bile duct that should be just close to the probe, between the probe and the portal vein.
Okay. Maybe here. Yeah.
Yes. Okay. So I try to push a little bit more the scope with the tip. What we can see here is the lumen of the CBD, that is the hyperechoic line that you can see, and the thickening wall of the CBD. Now we try to follow the CBD towards the hilum. Okay. I'm working also with the small wheel. And as you can see, there is all the CBD that is completely closed by this lesion.
Yeah.
And the hyperechoic line inside is the lumen of the CBD again. And I would like to follow more.
Maybe up to here.
Yes, thank you, Adrian.
A very unstable position in the bulb, and you have to be with the wheel deflected upwards, I think. So
Yeah,
it's a
little bit deflected, but and also the small wheel in this position is very important to use. But
now you nicely you can appreciate the hepatic artery, the portal vein, and also the bile duct, which is filled with something here.
Okay. So we are able to see also the cystic duct just here. We have
a small one.
This is the CBD, yes, and close to the right side we have the CBD, the cystic duct.
Yeah.
Seems to be involved as well. Again, I rotate it anti-clockwise now. Così.
Sorry.
Again, I would say that the dilation of the CBD just upon lesion is more or less 9 millimeters.
With a lot of lymph nodes as well. So
yeah,
you can see one here.
Maria Adrian, it looks like this thickening of the common bile duct is not really something, because now I think that you see that one of the hepatic ducts going into the liver. So the dilation starts probably right here. So from this part that you now
also here
are looking, yes.
Yeah.
This is probably the part of the gallbladder. Yes.
The gallbladder has also thickened walls, and there's a large stone in the gallbladder. We'll try to. It was visible at one point from the antrum, but you can see it here.
Yeah.
So that's the gallbladder. Mara is nicely showing, and with large stone there, but that's a different thing. So it's the obstruction is probably the level of the hilum.
Yeah. Try to show again this.
Yeah, issue that you show here, lymph nodes and.
There are many lymph nodes around the hepatic hilum also.
I think you have it here. So that's the bile duct most probably.
Yeah.
Yes.
Yeah. So all the landmarks are changed, but we think that the bile duct is involved, and I think it can be targeted by FNA, but the position is quite unstable. You can see that the endoscope is going in and out.
I feel confident that you can do that.
Yeah, I'm sure Mara can do it. I'm pretty sure.
We try to do it. And try to reach the second duodenum, just to have a look also from the third position.
Yeah.
Okay. Now I pull back the scope, looking for the mesenteric vein. Okay, we have the pancreatic duct here. And the CBD, the intrapancreatic CBD, the distal part, that is normal. And try to follow the CBD now from this position, just rotating the scope anti-clockwise.
Mara, good morning.
But
Andrea
the
from
CBD looks normal in the terminal part, I think,
yes.
in the intrapancreatic portion.
Yeah.
You see that Mara is using a different orientation, left-right, so that's not a problem, but you have to bear in mind that this small h, it's the position, the cranial caudal position, so it's either an H or an F or a dot in other ultrasound systems, so you have to be careful on the orientation, left-right, but it looks normal here.
Completely normal. You see, this is the wall. Now we are going towards the hilum again.
Here already you see infiltration probably, which looks pretty suspicious. Yes, so it looks like malignant.
Here.
Mara, good morning. Andrea from the audience. And we received some questions online.
Yes, please, but could you speak a little bit louder?
Sorry. Good morning, Andrea from the audience. We received some questions from the audience about the differential diagnosis between a pathological neoplastic infiltration of the common bile duct compared to an autoimmune cholangitis.
Autoimmune cholangitis, okay.
I think in this lady, because she's 78 years old, I think, and because the jaundice had a recent onset, I think the probability of malignancy is pretty high. So we are already dealing with high probability of malignancy in this case, with a lot of lymph nodes. Of course, autoimmune cholangitis has to be included in the diagnosis, but I think Mara is nicely showing the CBD, and I think she will do a puncture anyway. So we will need confirmation by either cytology or histopathology for the lesion.
Okay, I think we can proceed with the FNA.
Yeah.
But can you tell us if the aspect is more like a mass or more like a thickening of the wall of CBD?
The whole wall is thickened, but I think it's it looks, for me, it looks more like a mass in which it was growing inside of the bile duct.
Yeah.
And it's located in the proximal part of the CBD, affecting the confluence?
I think it's in the middle part or towards the hilum, actually. The terminal part of the CBD is normal. It's the middle part which is affected, and there are a lot of lymph nodes which have a lot of criteria of malignancy, if you can take that into account. Most of them are round, hypoechoic, very well delineated. So, but the position is quite unstable, but you see now that the CBD is usually close to the transducer in the first part of the duodenum, so this is a place that Mara can target. So the needle will come from this H here, so from the left side of the image.
Okay. Is it possible to measure the wall of the CBD?
Yeah, the wall is not so thickening in that
but you see here
the proximal part, but the mass is here.
It looks like a hypoechoic infiltration.
Right.
So this is not normal.
Yeah, I think that this mass that you are targeting with
I would like to go there.
With the arrow is the target of your biopsy.
Yes.
Exactly, and you see the dilated bile duct immediately above. Yeah. So the actual mass is here.
Can you show us also the elastography here and the FI of this mass?
We can show you the elastography.
Great, thank you.
I'll try to make the region of interest a bit smaller. Here you'll get a lot of artifacts because you have the bile duct nearby. Yeah. But if we can get rid of the dilated bile duct, then most probably here. So you see it's a mixture. The problem is that the position is very difficult. So for the scope, but I can stop it here, and then you can move back and forth. And you can also do frame averaging if you try to get rid of the artifacts. But most probably here it's okay.
Yeah.
So on the curve you have to look at the decompression, not on the compression side, on the decompression. So here it's let's say it's a decompression during elastography, and you see how it looks like. But all the vessels induce artifacts, three-color artifacts. So you have to take that into account as well.
Yeah.
And Mara, the target of your USFNA will be the common bile duct thickening or also the lymph nodes?
No. I would like to go just in this position where I see the lesion, the real mass that close completely the duct. I think that the thickening of the wall that we have seen could be also just inflammation. I don't know, but for sure this is the solid component who is the most important lesion that we have to target and biopsy. We can see just behind this lesion the dilation of, I think, left and right duct. So the lesion starts from just below the bifurcation and then going like this, yes.
And it's highly suspicious. You see that it's infiltrating, it's diffuse, you don't see clearly the margins. So I think there are more arguments for malignancy here than autoimmune cholangitis, I would say.
Okay, so now I proceed with the biopsy.
What needle are you using?
25 gauge needle from Boston.
Okay. And it's an FNA or FNB?
It's FNA.
FNA.
Yes.
Okay.
Adrian, could you comment on this is a metastatic disease, so it's the vascular staging is not that important, but what's your feeling about the hepatic artery and
the hepatic artery is really close. So I would say it's most probably it's involved. You see the mass here. Now you see the needle very nicely inside the mass.
Ferma.
So Mara is slowly advancing the needle, so that it's a very precise procedure, and it's really safe because it's a fine needle. So although the vascular elements are nearby, so that's you can see that it's really close to the hepatic artery. But if the procedure is done carefully, then you can avoid all the vessels, and it's a fine needle. It's a 25 gauge needle. So now you can clearly see that it's inside the mass. The mass is also close to the portal vein here. So I would say it's probably invading the hilum.
And
at
this,
this stage.
this is very important because we know that EUS is very important to perform the transversal staging and not the longitudinal staging of the cholangiocarcinoma, particularly the transversal staging on the vessels. So this picture that you are obtaining are very important to perform. In this case, we know that it's metastatic, but it's very important to perform in every case that the vascular infiltration on the transverse plane. So what's your plan now, Mara? Are you taking another biopsy for the Vivascope?
Yes, absolutely. Yeah.
Okay. So while you are taking the second, first of all, congratulations. Very, very nice procedure. We move to present the next case. Thank you very much.
Yeah.
Lui, Adrian.
The following case is about a 64 years old male with no remarkable family history and a history of appendicectomy in 1992. For steatorrhea and loss of weight, he underwent a GDS with colonoscopy with no pathological findings and following body CT scan, which showed a 5 centimeter inhomogeneous lesion of the pancreatic head with sign of infiltration of the mesenteric vein. The blood test showed increased CA 19.9 and the regular cholestasis index. So today's procedure is a US with fine needle aspiration with rapid on-site evaluation, and the operators are Professor Sowade and Professor Saftoiu.
Hello, Assad.
Good morning. Good morning. Paulo.
Good
How
morning.
are you? Good. Good morning. So basically, you heard the presentation. First of all, I'm using today the Olympus, the UCT 180. It's the linear echo endoscope by Olympus, and we have this nice presentation. First of all, I have this wonderful team around me, so I'm in very good hands. And now Adrian has joined me from the other room. So we have, the perfect start. I promise you this case is going to be interesting because initially when it was presented to me, I thought this is like a straightforward mass in the body of the pancreas, and let's show some, techniques for FNB. But again, I did the exam before we started, and this is the body of the pancreas. And I looked at the head of the pancreas, uncinate process, they look fine. But what struck me is the lesion. It is, first of all, it's unusual. It is not solid.
Could we please have the EUS image larger,
yes.
please?
Yeah.
Okay, I'll try to show you. This one?
Yeah.
Okay.
Thank you.
Make it a bit bigger. Okay.
So again, when you look at this lesion in the body of the pancreas, what strikes me is there are a lot of anechoic structures inside it. And this is a large lesion. It's about 5 centimeters. The pancreatic duct proximal and distal to this lesion looks fine. But when you look at it, first you think, okay, so it is hypoechoic lesion. So are these vessels? So the first thing I did is to do the E-flow or the color Doppler. And as you can see, hope you can see well, nothing lit up, okay?
And sometimes it depends on the gain, but
right. We kind of changed the gain as Adrian is saying, but there is nothing. So it doesn't look like these are vascular structures. So the second thing is we did the DFI, and we can do the DFI here. Okay. And as you can see, there is not much with the DFI. And there are these kind of structures. Again, there is some hypoechogenic parts of this lesion that is, again, it's about 5.5 centimeters in the body of the pancreas. But there are these multiple anechoic lesions. So then we started thinking again, what can this be? So this is a gentleman in his middle 60s who had this solid mass on CT scan. But now we have this, I would say, cystic lesion with some solid component.
How
so
large
it is about, yes, we measured it. Let's measure it again. It's about 5 centimeters.
Because
all the way
this
to
one,
this is one of the components, right? But
it goes maybe like this.
Yep. Okay. So basically, to show you the whole lesion, you just go back and you look at it here. Everybody can see the lesion, right?
So would you say what would be your diagnosis until now?
The differential diagnosis, I will discuss it. So let's start with the cystic lesions of the pancreas. This doesn't look, of course, to me like a mucinous cystic neoplasia. I mean, everybody would agree on that. The gender, the type of the lesions, these are generally microcystic. They're not macrocystic, and they're multiple. So multiple cysts. You would think of a serous cyst adenoma. It can happen. This is not a typical appearance, but it can be a serous cyst adenoma. It's side branch IPMN is a possibility, but it doesn't usually look like that. Another entity which I've actually published on, which is the solid pseudopapillary tumor, is a consideration. Although in my series, the majority were young women, less than 25 years of age. There were two exceptions in this series, one woman who was in her 50s and a gentleman who was in his 60s. So that's still a possibility. Now, Adrian is doing some elastography, and you can see that there's, what do you think of the elastography, Adrian?
Yeah, that's one of the exceptions, let's say. I think it might be a serous cyst adenoma. That's one of the exceptions of the elastography is that serous cyst adenoma looks like it is very hard.
Correct.
But actually, you have a lot of fluid-filled spaces, small ones, which gives you tricolor artifacts. So actually, it's not a hard lesion. It's a lot of artifacts in there. Serous cyst adenoma looks like a hard tumor on strain elastography, but it's not hard, it's soft.
It's soft. So always a microcystic serous cyst adenoma is in the differential diagnosis of solid lesions. And this is, again, on our differential diagnosis. So there is a serous cyst adenoma, less likely a side branch IPMN. There is probably less likely also the solid pseudopapillary tumor. The other cystic lesions in the pancreas, like the cyst adenoma, the lymphangiectasia, and the squamous cyst, don't look like that. Neuroendocrine tumor with degeneration can be, of course, cystic, a good percentage of neuroendocrine, but it's separate cysts. Do you have any experience with that, Adrian?
Yeah, I think we should also do contrast because serous cyst adenoma has a lot of septations which are usually highly vascular.
Highly vascular.
You can appreciate that also with confocal. You see a lot of microvascular networks.
That would be a good case.
That's a good.
Yeah, that would be a good case for CLE, but we cannot do the CLE now, because there are typical features for serous cyst adenomas on the CLE. So we will go ahead and do the contrast enhancement. Although we got the DFI then, and it was negative, but it's still worth doing it.
I think the sensitivity of contrast is higher than DFI. So I would say we could do contrast and then apply DFI with some contrast.
Tell me when you're ready.
Is the Wilson duct normal?
Yes.
So
can you start?
The mechanical index is 0.22. So I'll just get a bit like this.
Is the timer on?
Well, we started as soon as the contrast is necessary.
Okay, now it's on. Not much inside.
Yep.
You see already there's contrast in some of the arteries nearby, but
not inside. So. So we're at the 24-second mark. You can see some uptake inside,
but not much.
But not much.
You can see also with the accumulation mode, if you look here, that's the lesion here, and there is some signal inside, but less than the surrounding pancreatic parenchyma. So.
Yeah. So basically, the issue is gonna end up being tissue is the issue. So
now you can apply. Can we apply DFI so we get out of the
out of CSI and DFI.
Yeah. You see the signal in the splenic vein and splenic artery, but there's nothing much in the maybe
And the lesion
some
itself,
vessels,
yeah.
maybe some vessels there.
Professor, could you please show us the relation between the main pancreatic duct above the lesion?
You mean the pancreatic duct? You can see the pancreatic duct. Can you point at it, please?
And there is
Let's get rid of the
an atrophic
FI.
parenchyma?
Yeah.
Maybe here. Not sure.
This is on the left side of the screen.
I think
On the
this
left
one,
side here,
yeah.
you can see part of the pancreatic duct here.
Maybe
Yeah.
part is
Yes.
here.
Yeah.
And part is
Part
probably
is here.
here. Yeah.
So this is it. These are parts of it, and they're not dilated. They're actually very small in caliber, but this is the lesion again.
Looks a bit strange. I mean,
Yeah,
it's not a typical
it's a very unusual lesion, but I guess we're gonna end up with a biopsy with an FMB and trying to get to the bottom. So we're gonna use the Charcot 22, and this is basically a Francine type for people who are not familiar with the type of needle biopsies. We do have like the major ones we're using now, or the Francine type, where you have the procurement from the forward, from the tip of the needle, unlike the older ones, which were like side procurement. So again, this is a 22 gauge Charcot needle. Let's just stabilize this a little bit. Are we on the mode, the THI? Can we go to the, no, we're.
We can if you want.
No, that's okay. Keep it like this. Okay, and let me just magnify the view a little bit. And let me look here. This is the splenic vein. So let me magnify a little bit here.
They think it involves the pancreatic duct. Am I right?
Yes, it probably does, but I don't like the THI image. Let's go, yeah. Yeah. But is this the, let me not make sure. This is the splenic vein.
The splenic vein.
Yeah, and this is again the lesion here. So I think that would be a good place to biopsy it from. Can we stabilize the scope here? Yes, please. Okay.
Yeah, so now you have the sheet out and the needle out, and then you withdraw the
Can you do
stylet.
that for me? Can you please withdraw the stylet?
I can withdraw the stylet like this, maybe.
Yes, okay, so. Let's not find those.
Okay, now you're probably in.
Yeah.
Yes.
Yeah, we are in.
Looks very hard because you're pushing all the pancreatic tissue with it. Yeah.
I can see
but you're probably in.
Yeah, can we do slow pull, please?
Yeah, you can. Yep.
Do some fanning. It is fairly hard, fairly indurated, which is.
And you see the tip of the needle very well inside. So. Slow. Okay.
Okay, done. All right. Let's see what we have.
You want suction as well?
Yes, let's do that.
Okay.
Because it's hard, it's indurated, I will use some suction. Okay, got it?
Sorry?
The elastography showed exactly that it was not.
Yeah, it is. Yeah.
Okay, let's stop the suction, please, and remove it. Yeah. And we'll be out. Okay, that's not this. Okay, we can pop it and remove it. So now we will send this for the cytopathological examination. We can keep this.
And please, what's your opinion before rapid on-site evaluation? Was it an adenocarcinoma or a benign inflammatory lesion?
Yeah, I'm sorry, can you repeat the question?
What's your opinion before rapid on-site evaluation? You think it will be an adenocarcinoma, an inflammatory?
I don't think this is an adenocarcinoma. It doesn't look like an adenocarcinoma. It's a microcystic. Again, I'll stick with the differential diagnosis that we discussed before. It's not going to be easy for our cytopathologists. Of course, we have expert cytopathologists, and we're going to use also the fevoscope, right? So, but again, I would stick with the serous cystadenoma and possibly with the solid pseudopapular tumor. What do you think, Adrian?
Brianna, I agree. Whenever, I mean, imaging is helpful probably in 95% of the cases. It won't clarify the diagnosis before pathology in all the cases. Whenever you see a peculiar appearance, which is not consistent with what you know, then it's most probably a rare pancreatic tumor. So we'll see if it's a serous cystadenoma or a solid pseudopapular tumor. It doesn't look like an adenocarcinoma. It doesn't look like a metastatic lesion in the pancreas. Maybe it's a neuroendocrine tumors, but they are not microcystic like this one.
Yeah.
So we'll see.
Yeah. So what do the audience think? We will wait for the cytopathology.
Anyone from the audience want to comment? Please, Andrada.
How many passes do you intend to have?
So we just did the
we just did the first pass,
Yes.
and we're waiting. We're going to do more, but we're just waiting for Rose and then the second one for the fevoscope.
Is the diameter of Wirsung duct different before and after the lesion?
No, it's the same. It's not affected, and that's we could see it at the level of the tail and at the level of the neck. It's not affected, and the parenchyma looks pretty nice on both sides. So this is, you know, a very kind of discrete lesion in the middle aspect of the.
But you see it extends outside the pancreas.
Yes,
so
and that's why it's 5 centimeters.
I mean, here it extends, and it probably involves the splenic vein here.
Please, there is Professor Santo commenting from the audience.
Yes, please.
Hi, Assad. The question is, I think that the report said that the patient had steatorrhea. So how steatorrhea is going to be connected with this finding?
Yeah, it shouldn't, because the parenchyma of the pancreas looks fine. And it's, by the way, not in the head, it's in the body of the pancreas. I don't think, I mean, I don't know personally if he does have steatorrhea or no, but this will not explain steatorrhea. The rest of the pancreas looks pretty good. Yeah, so the question is, what is it? The CA19-9 was also normal.
Focal pancreatitis?
While you discuss on that, we go to the pathology room in order to have the first case that has been performed by Mara. Thank you. We move. Okay. We go to the pathology room.
It's an interesting lesion.
Okay, Claudio.
Okay. So this is the procedure, the material obtained by Mara with the inside the bile duct. So the material is quite abundant, mainly composed of epithelial glandular cells that look quite normal, but there are some area like this one. Can you see the screen? Yeah. The screen. This is normal, almost normal looking glandular epithelial cells, but this area and is the architecture is quite disturbed, and also here, and looking in this picture, you see that the epithelial cells are very different, dark nuclei and atypical nuclei. So I think that this case could be starting as an intraductal papillary neoplasm, mucinous, and becoming with malignant transformation.
Claudio, sorry to disturb you. Can you comment on the fact that you changed the color? How you do that?
This is a zeta stack on the picture taken by the Vivascope that can evaluate a different plane of the section. So the material is thick, but the instrument can have a different plane of visualization.
I see. So you go deep or closer. So
yes,
it's not a coloration, but the fact that the laser
a change
is going
in the different level of the like different sections.
Ah, that's great. That's great. So the final diagnosis
is adenocarcinoma, probably starting by an intraductal papillary neoplasm.
Okay, thank you very much. Brilliant diagnosis. So now we can go back to Hong Kong. Hello, Anthony. Here we are. Good to see you again. So you can start your second procedure. We can't hear you.
2 years old ladies here with presented with an acute necrotizing pancreatitis 10 months ago, resolved with a conservative treatment, but subsequent follow-up CT shows a 10 cm peripancreatic collection with some solid debris inside. Overall picture compatible with wall necrosis. The patient has repeated admission for epigastric pain. So in this session, we plan to have a US-guided drainage for this suspected wall necrosis.
So the plan today is to use a new stent. So this is the zero stent. Okay, so it's a endoscopist controlled hot cautery enhanced luminal pulsing stent. So you can see the handle. There are several knobs. So this knob is to advance the delivery system. And to open the proximal flange, we use the gray knob. The tip of the stent has a cautery enhanced tip, so very similar to axials. So we can use this tip to do a direct puncture. So let's change to the US view. So you can see my scope has already been inserted. So you can see a large juicy collection. So this is measuring around up to 8 centimeters. There is some solid debris inside. You can see maybe around 30 or 40%. We are doing a randomized trial right now. So trying to decide whether we should do an early necrosectomy at a time of drainage versus interval. So may I ask the panel, what is your preference? Do you usually do necrosectomy at a time of drainage or you wait till later?
Here in Milan, we prefer to perform necrosectomy in the second time frame. So first put the stent and then look to the outcome in the patient with the stent and then go to eventually for necrosectomy. I do not know the other colleagues here.
Yeah, I think there are various ways of doing it. For us in the past, we also would drain first and then followed by necrosectomy. So right now we are seeing if doing an early necrosectomy at the time of drainage would benefit the patient. So you can see my stent coming out right now.
Yes, we see it perfectly. May I ask you what setting are you using for the generator?
This is exactly the same as we would use for all our cautery enhanced devices. So AutoCut either 4 or 5, and then effect, and then at 100 or 120.
Yeah, just because this is a brand new stent, please go ahead very, very slowly and explain everything, please. Thank you.
I'm gonna burn my way through. So burn. So you can see it went in very smoothly. All right, I'm gonna turn on the X-ray so you can see the X-ray view as well. Okay, after going inside, I'm gonna push in the wire.
Do you always use the wire in these procedures?
Not always, but in this patient, since we're planning for an early direct necrosectomy, so we plan to dilate the stent.
I see, okay, great.
So next step, you can see, focus on my hand, and we have large image, endoscopic image, large.
Yeah.
Okay, here, I'm going to turn this knob 180 degrees. Okay, 180 degrees.
Yeah.
And then I'm going to open the stem by push back. So can we have the US view as well? Right, I'm going to push the stand backwards. I'm going to turn on the X-ray so you can have one more direct dimension to see. So you can see the stand is slowly opening.
Yeah.
All right.
Yes, 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 yes.
So right here, there's a click. And then it means I have already opened around a third of the distal flange. So now I'm going to turn 180 degrees again. Right, that's another click. I'm going to open the stent a bit more. So you can see the stent opening a bit more right here. Okay. And then I'm going to pull back the stent. So right here, unlock. Pull back the stent. So this stent is 2 centimeters in length. All right. Okay, so I think this is okay. So I'm going to open the remaining of the stent again in the channel. So can we have the, okay, you can keep this view now. Can we change to endoscopic view? Endoscopic view.
How you feel that is completely released into the channel? Do you have any click
already.
on the?
Yeah, so the stent should be open completely right here. So on the handle.
Great.
So already open completely, and I push it out from the channel. Right here, maybe not completely open, the proximal flange. Right there. Okay, so but it's draining, so I'm going to dilate that slightly, the stent, because maybe the proximal flange is not completely open. So let's exchange.
So now are you planning to dilate the stent?
Yeah, yeah.
Yeah.
So
to what size are you?
So this diameter is 16.
16. Okay. And then are you going to perform necrosectomy at the same stage?
Yes,
during this session?
Yes.
What about the risk of dislodging the stent in this early phase?
Yeah. Well, there's of course always a risk, so you need to be very gentle. And but then if it's dislodged, we can always have a way to deploy it using the channel.
So are you moving to a gastroscope? Are you moving to a gastroscope now, or are you using the same?
I think we will use the ES scope to dilate first, and then change to a gastroscope. Wow. So you can see this endoscopist controlled delivery systems. Again, it's very user-friendly and allows a lot of precision for the endoscopist to deploy the system.
It looks very simple. It looks very simple.
Yeah.
But it's performed by you, so everything looks very simple.
Oh, no, of course not. So, and then the lumen opposing force actually is similar to axial. So you can perform we have performed a GI anastomosis, and the stem seems to be able to oppose the 2 lumens quite well.
I see. And do you also dilate when you perform the gastroenteral anastomosis?
Actually, we usually don't dilate and just wait for the stent to open by itself, usually the next day. Okay?
Great.
Okay, can we inject? Yep.
Hi, Anthony. It's Amy Tyberg. Can I ask you a question? Hey. I saw that when you open the stent, you open it a little and then turn 180 degrees and then open the internal flange the rest of the way. Is that so you can readjust if needed, that you have to turn it in the middle of opening it? Or can you recapture there if you're not happy with the position? Is that the reason for that extra step?
Well, actually, it's the design of the stent. So they give you 2 stages. So the first stage, you turn it 180 degrees, open part of the stent, and then the second stage, you actually do need to turn another 180 degrees. So if you don't turn that 180 degrees, you cannot open further. And in terms of recapturing, I think you can actually recapture, yes. Okay, so we are dilating up to 15. Okay. Okay. So I think we probably won't need to have it too long. So deflate, please. Keep wire. Okay. Okay. So we're going to exchange and keep the wire.
Anthony, just a technical question. Is your patient intubated actually?
Right now, we're not. So I think in the States, you always intubate the patient. For us, we don't intubate as much. We try to keep a good suction and just to prevent the patient from aspirating. And in fact, a lot of our procedures are done under sedation.
But is on deep sedation.
Yeah.
Yeah.
And Professor Teo.
Right, I think I'm going to change to a gastroscope.
Yeah, we will stay with you until you enter the lesion, the cyst, and then we will move.
Okay, thank you.
First of all, thank you very much for this great demonstration of this new stent. I'm very curious, and hopefully we can have also in Europe or in the United States very soon to test also in our patients.
Professor Teo, about direct endoscopic necrosectomy, do you perform in the same session and you based your choice about the amount of the debris or clinical condition of the patients or other suggestions you can tell us?
Yes, usually we are running a trial right now. So in the patients with moderate to severe necrosis, so between maybe 20% or above, then we would consider a direct necrosectomy. So we are running a trial comparing early versus interval. So of course, with all these devices, we can perform early necrosectomy. And especially with the neo and necrotectomy device like a endorotor. So necrotectomy can also be performed quite easily. So I think the benefit is of early is really to reduce the amount of reinterventions and also not having the patient need coming back for repeated procedures. But of course, if you do it interval, then there is another school of thought where people would say maybe the necrotic material is better demarcated. So meaning it might be easier to remove. So this is more of a traditional kind of surgical teaching. Okay, so the
Usually, do you proceed for immediate necrosectomy, no matter of type of lamps that you use, or particularly in this type of lamps?
Can you say that again? Sorry, I couldn't hear you.
So you perform immediate necrosectomy in all cases, in no matter the type of lamps you use, or just when you use this type of lamps?
Yeah, we are running a trial, so we are randomizing patients. So right now we don't know which is the better way. So direct versus interval, we're not sure which is the better way. And for this patient, she is actually randomized to a direct group.
So Anthony, thank you very much for this fantastic demonstration. We leave you in this necrosectomy that sometimes takes several hours. Thank you very much to you and your team for letting us participate to these two great cases that you have performed. Thank you very much again. See you very soon and probably next year. Thank you.
Okay.
Thank you, Anthony.
Thank you very much.
Bye-bye.
Bye-bye.
So now we can go back to the room, to the radiology room, where Dr. Mariani is taking care of the patient with the diagnosis of cholangiocarcinoma. Alberto?
Good morning. Can you hear me?
Yes, we can hear you perfectly.
We are starting the procedure using a Pentax duodenoscope EV35i 10T. And we cannulated the papilla using a wire and a locked wire by Cook. I am using a wire by Cook, and I avoid any contrast at the moment because it's very important to underline that in that case, we have no cholangio MR. Cholangio MR is a crucial procedure that can provide a roadmap for an optimal biliary drainage. So we have that we know at the end of the US that there is a lesion of the proximal portion of the common bile duct, likely involving the hilum, with a not communication between the left and right liver main duct. So my goal is to preserve the patients of any injection because the rule is to avoid contrast as soon as possible to obtain a decrease of risk of infection when we opacize the duct without any drainage. The wire is go into left liver, and now I inject the contrast in the common bile duct to verify the site of the lesion.
Could we have X-ray, please?
Cytology was for an adenocarcinoma, as previously spoken, and is this probably a degenerate IPMN of the proximal portion of the bile duct. Now inject, please.
Could we have X-ray image larger, please?
Have you the major, X-ray major?
No, small one.
Sorry?
No, okay. X-ray larger, okay, perfect.
Contrast, please. Contrast. Stop. The first result is a common bile duct with a very low caliber. This is very important to plan the stent displacement because the caliber of the common bile duct limited the number of the stent that we would put in place. Stop here. Contrast. Stop. Now we can see the stricture that is placed in the proximal portion of the common bile duct. Scopia. Stop. We have the opacification likely of that of the right liver, while the wire is in the left liver. Dimensione normale.
And you suggest always to inject below or above the stricture?
Now I try to go above the stricture. Contrast. Contrast. Stop. Zoom. Contrast. Sotto, sotto. Venga sotto, per favore. No. Ancora? Devo vedere in alto. Ok. Stop. Copia.
Alberto, can you please help us in the interpretation of the cholangiogram images, please?
Sorry?
Can you please help me in the interpretation of the cholangiogram?
Contrasto. Metta più piccolo. Vediamo. Ancora. Contrasto. Basta. Me lo sproietta, per favore. Ok.
So Alberto, what's your feeling actually on the
I
basis?
try to identify the site of the stricture. Copia.
It looks that the hilum is involved.
Contrasto. Contrasto. Stop. Copia. Contrasto. Now I under the stricture. Contrasto. Contrasto. Stop. Copia. I have a dilation of all the left liver, but it's difficult to identify the proximal portion of the lesion. Mi può proiettare? No.
I think that they need to open the hilum because probably you have something that is over-impressed, and so we cannot see the hilum very well.
Stop. I try to deplace the wire to search another duct. Stop. Copia. Contrast. Now we are under the stricture.
So Alberto?
Contrast.
Alberto, can you hear me?
Yeah.
Yeah, so while you are trying to deal with the stricture in order to see whether to put the stent, we move to the next case in room number 6. We will be back in a while. Thank you very much.
Okay.
The following case is about a woman of 63-year-old, and sorry. In May 2022, a diagnosis of metastatic pancreatic body ductal adenocarcinoma was made. Then she started chemotherapy with the PAX-G protocol and recent admission in our emergency department for gastric outlet obstruction symptoms. She underwent a gastrointestinal series that shows a dilation of the duodenal to the detritus with a contrast medium stops due to a tight stenosis from non-pancreatic infiltrative lesion. This is the gastrointestinal series image. And today's procedure is a guided gastroenterostomy performed by Professor Di Matteo from Rome and Professor Michel Calais from New York.
Hello, Francesco, can you hear us?
Yes.
Great.
Great.
We can hear you perfectly. So, good morning.
Good morning to everyone. I'm a lucky guy, most of all because I got a wonderful staff. Noemi, Laura, and the anesthesiologist Gabriele, but most of all, I got an opinion leader, worldwide known, Michel Calais, on my shoulder. Thank you so much.
Thank you, my friend. Thank you.
An easier procedure with this stuff. And most of all, because I'm playing with a new probe, EG 740 UT by Fujifilm and Arietta, the brand new equipment. Unfortunately, we cannot show you the performance of this machinery because we are doing something else. We don't need elastography, we don't need DFI and so on. But as you heard this morning, we got a stenosis very far from the contact with the stomach because it's a pre-tried stenosis. So we use a guiding catheter, the iBreast one from Cook 7 French, with a guide wire. Which one was it, the guide wire? Hydra guide wire by Boston Scientific, and nurses were able to pass by the stenosis, and now we are filled up the loop. As you can see, is we didn't use any drug now. We are injecting water, as you can see, contrast medium, to let you show on X-ray where we are.
So it's very important to understand that this is probably one of the most difficult locations when you want to do a GE. Why? Because it's literally at the ligament of Trites. So Professor Di Matteo literally had to cross the obstruction, facing the obstruction endoscopically, in order for him to then distend the bowel. And you can see that in this case, he decided to use that 7 French tapered tip catheter from Cook because the stricture was so tight. And then he was able to distend the bowel, and now he's back with the EOS scope on the left side, trying to find a nice piece of bowel. We just saw a nice piece of bowel. He's trying to distend that piece of bowel a little bit more. We gave another Buscopan, and then we're gonna try to find a nice piece of bowel and orient ourselves into the longitudinal adherence. That's a beautiful piece of bowel. And you can see it's well distended. It's not moving much thanks to the Buscopan. And so you see he's lining himself up so he can have the best orientation. We're going to give a little bit more Buscopan so that the bowel will really become completely immobile. Very nice area. You can see the loop of bowel back in on itself. That's probably one of the most reliable signs on EUS that you are dealing with the small bowel and not the colon. You have to find those twin, loops, and then obviously orient yourself in a longitudinal fashion so you can deploy your lumina posi stent. This is a really boot camp EUS guided GE that we are experiencing during this course.
Which stent would you like to use, Axios or Spaxus? What do you have? Axios one, okay.
Okay, so Professor Di Matteo wants to use the Axios. So we need to make sure that's the right settings and the patient is padded appropriately. We went through all those, points yesterday.
I'm trying to avoid to pass this vessel.
Okay.
Yeah, so unfortunately I've changed my position. This was good enough, but could you show X-ray, please? Yes.
So he's trying to figure out a way to avoid that large vessel. Maybe here, yeah.
Vedi ancora?
This is always the most difficult part, to target the bowel loop in order to be in a good position, and with the dilated loop is the most difficult.
Right. Okay.
Okay, I think we find a decent angle here. I don't see any vessel.
Okay. Avete lo stent?
All right, so he's measuring the distance between the lumen of the stomach and the small intestine that he's targeting. And you see a very important thing that we can notice is doing, he's trying to limit the distance between the transducer and the target. That is a very, very important maneuver in the EUS. Always try to put that transducer the closest you can to the target so that you have the smallest angle possible. Okay, so we're gonna get ourselves set up. Nice piece of bowel there, nice orientation.
And Francesco, Michelle, Andrea from the audience. Of course, in Europe, and I think also in...
Can you speak louder, please?
Sorry, Andrea from the audience. Of course, in Europe and United States, we don't have the EPAS balloon that yesterday we have the opportunity to look at. But do you feel the need for a balloon dedicated for gastroenterostomy, or you feel confident with the freehand technique?
So this is a great, great question. I was recently actually in a conference with the Vinay Deer from India. And as you know, the Indians are probably the biggest users of the EPAS balloon. And I asked him, because he's doing GE using the EPAS balloon and without the EPAS balloon. And he told me that actually he's using it less and less. He has found that the placement of the balloon is very tedious. It's great once it's in place, but just to be able to place it at the right place and trap a piece of bowel between the two balloons, it was very tedious. So he's using it less and less. So that was very interesting, because you go back like 4 or 5 years ago, everybody was convinced that it was the Holy Grail. And now here you are, you have an expert that has access to the EPAS balloon who's using it less and less. So I believe that, you know, if you have a very good technique, you use, you know, glucagon or Buscopan, and you have a very distended bowel and a good angle, you should be able to perform this procedure safely, but you definitely need to have a coronary enhanced device. That's something that pretty much every single expert agreed upon. So we are preparing the axios here. The settings has been put into the Irby. Where is the Irby?
Gira il volto, lascialo pure il catetere, il volto verso di me.
Where's the Irby, guys? Okay, and we have the settings. Okay, what settings are we going to be using?
AutoCAD 6.
AutoCAD 6. So I'm obviously taking a big interest into sets even more now.
And for gas leak outlet obstruction, we usually use the 20 millimeter or...
I'm sorry, I cannot hear you.
Sorry, for the gastric outlet obstruction syndrome, you usually use the 20 millimeter stent. But there is some place for 15 or even smaller stent for other indications?
So it's very interesting, because we obviously started doing GE when the 20 was not available. And for people that have received the 15 millimeters for benign condition, for instance, they are now all coming back after 2 to 3 years. And we do what we call a little exchange. And it's a very easy procedure. You remove the 15, you dilate, and you place the 20. So I would say that, you know, if the patient has a very short lifespan, it doesn't really matter. But for benign disease, we've noticed that the 15 get occluded faster, and then we need to upgrade them to a 20. I have a patient in Atlanta that comes and sees us every 2 years to get what she calls her oil change, and we literally just swap the old axios for the new one. So Matteo is now placing the axios. He's about to enter the bowel. As you can see now, he's using EUS to get the best angle possible. So we're thinking we are inside of the loop of bowel. He's going to deploy the first flange. I don't know if you can see the image by EUS now. So he went really deep,
because that's the safest way to basically make sure that you don't deploy the stents at the border of the small bowel. X-ray, please.
Less body, less thorax.
So he's trying to advance the wire. Now that he deployed the first, here it is, the first flange. So you see the wire is only placed after the access into the bowel. You may be against the wall. You may have to pull back a little bit so that the wire can be advanced. I think you may be just against the wall. Yeah, you may have to pull back a little bit the delivery system. Okay. Sometimes I also notice that the delivery system during the access to the bowel, sometimes at the end it gets a little bit occluded. We've seen that. So what he's doing now is he's stable enough that he decided to deploy the second flange. You see the second flange has been now deployed into the lumen so that now very safely he's going to try to push the wire so he can keep access to the bowel before delivering the second flange into the stomach. So now very gently he's pushing that. Here it is. Lots of tension here. Lots of tension.
It's 20 millimeters, so we have to raise.
Yeah. So obviously there's much more friction with that. All right. So the second flange is deployed. So now he's gonna push the wire just to confirm. Where we are.
You have to see methylene blue. I don't see methylene blue.
We don't see methylene blue.
This is not a good job.
Okay.
Michel.
So
Francesco, I think that you are out.
So I think what may have happened here.
It was the same problem that we had yesterday.
Yeah, but here there's a difference because I think we have a very good access to the bowel. So I don't know.
I don't know.
I mean, if you want, we can inject contrast because if we have access to the bowel, I mean, endoscopically, we can convert to a nodes here if you want. We have the 2T channel. Paolo.
First, just check if we are into.
Inside.
But I don't think that you are inside also with the guide wire.
What we can do now is.
I think that the best thing is to remove everything, close the hole, and do the procedures again. The procedure again.
Right. We should take. So we take everything with a forceps. We remove everything. Foreign body forceps.
Yeah.
And
so
we do again.
So you want to do an Ovesco then?
No. Vediamo tutto on one side. And do you have a gastroscope? No.
You are really next to the bowel. Like you are right there. You are literally right there.
Okay. Dopo. Sì.
Yeah, no, it's possible. Yeah. My only concern, I want to make sure that there is the bowels are not. Yeah.
Adesso farò semplice per un Ovesco da 9. Lo montiamo subito, poi teniamo tutto così.
So Francesco, your plan is to close the hole with the Uvesco and then to try again.
Yeah.
Great. Okay.
So what we think happened is the tip went inside, and maybe the beginning of the flange was inside, but then because of the pressure, once we start deploying the inner flange, it popped out.
My feeling was that you had performed the hole in the stomach, but then there was this tend effect on the loop. So you feel to be in, but then you were out right with the tip. So when you open the flange was or has been open in the land of no man, as yesterday was for Cheyenne. So let's close the hole first, and then we go to have a look again. Then while you are changing the instrument, we can go back to room number 7 in order to see whether how Alberto is dealing with this his procedure. Alberto, can you hear me?
I am trying to calibrate the right lever.
Francesco.
It was difficult. Now I try to change this duct. I think that is
radiologica, endoscopica
of the right lever with the 8. It's possible because it was dilated.
So now you have 2 guide wires in the left lever, and you have a guide wire in the right.
In the right,
you are playing in the right.
Not in the best duct.
Yeah. Are you working with a hydrophilic guide wire, actually?
Before with a hydrophilic wire, yeah, and now we have a jack wire, Boston.
A jack wire.
The first one was an Acrobat wire, the second one a Delta wire by Cook.
So your plan is to assess to the right as well?
The drainage of the left and the right lever.
And then to put at least 3 stents. And we have supposed when we have performed the US. Which kind of stents do you plan to put on?
2 metallic stents.
At least 2 metallic.
Covered metallic stent.
So you try to put the metallic stent from the hilum to the duodenum, so not side by side.
Yeah. After the dilation of the stricture.
Yeah. Did you feel that the stricture is tight? Is very tight?
Yeah, I think because it was difficult to the passage with the sphincterotomy. Sophia. Fa una lupa. Progetto. Sophia. I try to cannulate the anterior of the right lever. Are qui.
Alberto, Andrea from the audience, do you choose for uncovered metal stent because you consider the stricture a type 2 according to Bismuth-Corlett classification?
Yeah.
Thank you.
Sophia.
Okay, stop.
Another wire, please. I try to cannulate another duct.
Would you like the delta again?
Delta again. Sophia.
we were able to access the right liver with the delta.
Yes.
But after we cannulated the right liver, we wanted to change it to a more stable wire.
Yeah.
In order to be safe in the right liver.
See. Stop.
So Alberto, are you changing the wire, the last wire that you have put?
Yeah.
But are you
No,
not
yeah,
or do you want to put
I stay with
another
the
wire?
last wire on the right liver, but attempting another dot.
Great. So we leave you for 1 minute because we go back to room number 6 to see Francesco, who is going to close the hole. Francesco?
Yeah.
Yeah.
We are now using a Ovesco 9mm with a standard gastroscope to find out the access through the stomach, but it's quite difficult because we didn't left the guide wire inside. So
maybe on this side.
No.
Okay.
It must be said that these holes are usually closed very, very, very rapidly.
Yeah.
If you don't.
Yeah.
If you don't.
I don't know. Probably with X-ray we are able to. Must be here.
Yeah, somewhere in here.
Could you give me a catheter, just a catheter to check if it's here or not? Seems to be here. Un catetere.
X-ray? Fluoroscopia?
Yeah.
No, ce l'ha dentro nel
Anche
paziente.
la pinza va bene.
Vuole una pinza?
Sì. Pinza. Just to check if this is the side of. This is 3.8 instrument, so we can use forceps nearby the Ovesco one. No, chiudi, non devo prendere. From X-ray seems this side, but I don't know. Probably, Michelle, we'd better to continue to find the loop. Is this?
That's it. Okay.
Okay.
X-ray. Copia? That's it. That's the place.
Okay.
Yeah, really, right there.
Yeah. Puoi levarla. Could you take me this, please? We are going just with it.
Okay. Now we're going to inject contrast.
Yeah.
To make sure that this is sealed. Can we have a syringe of contrast, please?
With a introducer, please, because I got this. No. With the introducer of the guide, the white one that you used with a guide wire. This one, it's great. This one. Contrast medium, please.
So we really were like literally in front of the bowels. We probably must have bounced.
Yeah.
So now, once we check that there's no opening, X-ray, please. Okay. All right. So it's completely sealed.
Okay.
All righty.
Okay, we remove everything and then we start again.
Okay. I mean, the good news now is the bowel are already distended a little bit. So we're gonna capitalize on the previous, inflation of the bowel with the water. So maybe we're gonna give another glucagon and give some more water. Then we give some more water.
Attento che te lo levo. Te lo levo.
Hello, Francesco and Michelle.
Yes.
While you move again to the other instrument, we just go for a few seconds in the pathology room because Professor Doglioni wants to comment the case performed by Assad Soway.
Okay, no problem.
Okay,
we're gonna get ourselves ready for the GG.
Yeah, see you in a while. Okay, Claudio.
Yes.
Here you are.
So I apologize and I am disappointed, but I have not a definitive diagnosis in this case because it's a very unusual case. And you see the material is quite abundant, but is composed of fibrotic tissue, many inflammatory cells, and some scattered epithelial components. There is no sign of malignancy, so I exclude pancreatic adenocarcinoma or neuroendocrine tumors, but it's very difficult to categorize give a name to this lesion. It seems inflammatory, but also another putative possibility is pancreatic hamartoma is a very rare lesion, but I never seen a case with cytological material. So this case needs more extensive histological evaluation. But now we have the material and we will give you the answer probably, I hope, in the next future. Okay.
So Claudio, do you mean that with the specimen that we have obtained, you will be able to give us a final report, or that this patient should undergo surgery to have the final diagnosis?
I hope to give you a final report on this material.
Okay.
Yeah.
Thank you very much. Thank you very much, Claudio. So we can go back to room number 6 because I see that Francesco is already in position. Francesco, here we are again. And Michelle, here we are again.
The same thing is he's trying to line himself up in a longitudinal fashion. You can see here, he has a very nice angle again. We gave glucagon again. Okay, and we're gonna get another axios. Okay, so if we can get it.
Serve glucagone Buscopan, please.
Ready? Okay. Yeah.
Could you tell us when you inject the drugs, please? So you are able to understand what we have to do. Sì. Ma senza farlo uscire.
Alrighty, so same thing. We're gonna get a guide preloaded into the axios.
Vedere?
This is a
cosa mi ha chiesto, scusa? No.
This is a angle wire. Those are very hard to place into the axios.
Could you show me the X-ray? Meno colonna, per favore, poco meno colonna.
So you literally have to feed the angle tip first.
Okay, stop.
I mean, they're nice, but they're very hard to, because the working channel of the axios is very small. Here you go. Okay, so we are wetting the
Mi fai vedere dov'è la guida?
So the wire is being preloaded. Okay.
5 centimeters more inside.
Vale.
No?
Okay. Alrighty, disconnect.
La posso aiutare?
Adesso mi vengono via tutte le...
Alrighty. All right.
Yeah.
So he's keeping the fluoro and the Doppler flow on. Very nice line up here. It's coming from the other side. This is the Milan way of doing EOS. Can be confused at the beginning. So you see he's lining himself up. He's outside of the working channel of the scope.
Yeah. I'm trying to avoid the vessel of the...
So he's keeping the flow to avoid the vessel. That's the reason why there's a flow going on. Very nice angle here. Okay, so I think you're I can just maybe a little bit more.
Yeah.
Advance maybe a little bit more. X-ray.
Can we have the X-ray image larger, please?
Yeah.
Do you, Matteo, do you feel that is working? Because I don't feel so. The Vio is working?
Yeah, the Vio is working. That's definitely the case. X-ray?
I don't think so.
X-ray?
No.
For some reason, we don't have a very good EOS vision.
US.
So I think we are.
Can I have the US image, please? 2.
Yeah, the EOS vision is not ideal. X-ray?
It seems inside.
X-ray fluoroscopy?
Yeah. No.
Yeah, no, the wire is not.
Yes.
Not sure about the wire.
Mm-hmm. No, don't use the word. Yeah. Okay. Did it?
Francisco, Andrea, frankly speaking, do you consider necessary to perform the second gastroenterostomy right now rather than postpone the procedure?
I think that is useful because you usually take the same way and you can fix the organ together. So it's better to, on my point of view, to close immediately, to try to close immediately. Vedere, metti altro liquido. Vedere?
Quello contrasto proprio.
Sì. Vedere?
Here it seems closer.
This is the area of the...
Yeah.
So what Matteo is trying to do here is trying to find the same location so that we basically seal with the axios the fistula created, because that's the issue now. We have a fistula, so it's very important to make sure that we are in the exact same loop.
Francesco and Michelle, don't you think that there is a loop in between this dilated and the stomach?
It's possible.
Yeah, this one that you see right close to the probe.
Yeah, it's a legitimate.
If you play with this,
yeah, we need to play and make sure that we are aware of that.
Yeah, because when you turn, I don't know if you need to turn right or left. But
For sure, there's a loop.
Yeah,
I remember the guide, there was an alpha loop. Just that's why I didn't use the other one. I try to.
Because you see, this is.
That's also the area.
This is the loop, and there is a loop in between when you turn. Yeah, this one.
Yeah, here it is.
Yeah, that's why I'm trying to avoid that loop over there, because I got enough space.
And Francesco,
this loop has has a U-turn here, so probably you are cutting it through the.
Yeah, so it's very important indeed to avoid the other loop. So this is where manipulation of the scope under EUS is very important. Explain why this was such a challenging procedure. Okay, I think now you're in the lumen.
We are too far from.
Can you put some more fluid inside?
The tip is definitely in the lumen. X-ray? Fluoroscopia?
No. Vedere, scopia. No. I don't think we are in the right position. It's too short.
Hi. I think you might be in the lumen. I mean, if you can.
It's too far from. Oh my God! It's too far from.
I know, but once you deploy the first flange, you can bring it.
Yeah.
So if you are in the lumen.
Vedere. Questa è la guida più morbida che avete?
Yeah.
When you see the X-ray, it looks that you have a strange direction with the outactors.
X-ray.
It doesn't look to be looped.
Push away the loop.
I don't know. I think.
No.
I mean,
okay, Michelle, Francesco.
Yeah.
While you trying to find out the best position, we go to connect with Mumbai because they are waiting for us.
Okay.
We'll leave you for a while, so we can move to Mumbai.
So go very.
Mumbai, yes. Okay, here we are. So we move to Professor Deer Hospital in Mumbai. Hello?
Hello.
Hello. Hi.
Can you hear me?
Yes, I can hear you. I can't see you, but I can hear you. So welcome
you will see me.
Welcome to Euro US. I hope that we are going to see you in 1 second, because we don't see you still. So it's
not yet.
So
just give me 1 second.
Yeah. Thank you very much for joining us.
Thanks, Paulo. Thanks a lot. It was nice. It's nice seeing you.
Yeah, it's very nice
You're
seeing
looking
you as
younger and
well.
fitter.
Okay, now we see. So now we see you. So Professor D in Ideal Care, Institute of Digestive and Liver Care in Mumbai. Thank you very much for joining us. And go ahead to present your first case. Thank you very much.
Sure. Can we present the first case, please? No. This is the wrong slide. Please put, this is the second case. Yeah. So this is an elderly lady who has a CA of the neck of gallbladder with a bile duct obstruction. She underwent ERCP and metal stenting 11 months back and decided not to take any treatment after that. So the stent luckily functioned for about 11 months, and now the stent has blocked. The patient is having fever, bilirubin has started rising, and the counts are high. So patient is in cholangitis. CT scan shows mildly dilated intrahepatic biliary radicals. Somebody has tried ERCP outside. She has come from about 400 kilometers away. They could not go into the D2. So they have referred to us for EUS guided drainage. We did a EUS 2 days back, and we found that there is an angulation at the D1, D2 junction because there are lots of large lymph nodes there now. There is a grossly distended GB primarily because of the cystic duct block. And of course, the CHD appears dilated. So we plan to do 2 procedures if possible. One is an antegrade stenting and second is a gallbladder drainage if time permits. So let us start this case. I am using an Olympus linear therapeutic scope. So we go in. Okay. So this is how the liver looks like. Are you getting the EUS pictures?
Yes, we got it. Thank you.
So not a massive dilatation of intrahepatic biliary radicals. However, there is some dilatation here, if you see. And then if I turn my scope clockwise, you start seeing this is of course the portal vein. You see these large necrotic lymph nodes here. This is not bile duct. These are all hugely dilated necrotic lymph nodes. See this? These are all lymph nodes. So I will show you the gallbladder later. First, let us start and see whether we can do an antegrade drainage in this patient. So I am at 43 centimeters, and if I go a little in, I am seeing the left lobe of the liver. There is faint ascites, very, very minimal. And this is the left hepatic vein. So we differentiate segment 2 from segment 3 and try to see Doppler. So not many dilated radicals here. When we come back and turn a little clockwise, here we are seeing some dilated radicals. Can you see here? So this is almost segment 2. Here we can puncture and try to get into the biliary system. So this we will choose. Can we turn the patient flat? So I normally do these procedures in supine position. So we are turning the patient supine. So this is one good dilated radical that I have found here. And I think we will target that here. Doppler. So there are some vessels around it. We have to see an area which is relatively avascular. Can I check the fluoro, please? So I always like to check the fluoro to see what is my scope position. You can see the metal stent there. Show me the diaphragm, fluoro. Okay, so I think we are in a decent position to puncture. I'll use a 19 gauge needle. So we are using the Olympus Easy Shot. Big vessels have to be avoided. Small vessels are okay. So we use this 19 gauge needle. I first see whether the needle is coming out or not. Okay, I can see my needle. Can you see the needle? So find the trajectory towards the bile duct. So we turn the scope again. This is our area. I am at about 44 centimeters from the G junction. And let me see the trajectory. What is the trajectory of this needle? So this is important that you target the bile duct properly, spend some time on this. Okay, so we are look like we are in. So to confirm it, we will aspirate and see that we are in the bile duct. So we are seeing white bile coming. Bas. Now we will inject and see what is happening here. Okay, so you can see the stent is blocked there.
Vinay, can we have the X-ray bigger so we can appreciate the X-ray actually?
Yeah, so you can see that there is a complete block there.
Yeah.
It is quite possible that stent has a little bit migrated distally. Now we are putting a bit of saline. The challenge is to pass the guide wire across the stricture because no dye. Okay, now some dye is going. Stop.
Yeah.
So now we will use a 032 Terumo and try to pass it across this stricture.
Yeah. While you're playing with the tumor, may we have the X-ray bigger, because actually we have the big echographic image, so we cannot see very well that you are playing with the guide wire.
You want the fluoro to be made big?
Oh yeah, because it's
okay.
It's very,
Can you make the fluoro big?
Yeah. Okay, great, fantastic.
So this is the complex part in antegrade procedure, the wire manipulation, and we are lucky to have Bibin, my assistant, with us, who is quite good, excellent at wire manipulations. And I think this is why these techniques are not very popular, because passing a wire across the strictures could be cumbersome. And we may end up doing just a hepaticogastrostomy if this doesn't pass. So we will spend some time and see whether it goes or not. So a salvage hepatogastrostomy is always a second option. No. So the advantage of Terimo is it rotates very nicely with your thumb and index finger. So we are trying to see the wire. Okay, good, good. Turn it in the other direction. Gently turn it. Magnify. We are magnifying the fluoro so that we can see better. Fluoro. ओके फ्लोरो एडजस्ट करो धीरे से नीचे दिखाओ स्लो शो डाउन या वेरी गुड हाँ अच्छा है इट्स नाइस so there is a tumor here which I think is not allowing the wire to go. We need to get a proper axis. If it doesn't work, then what we do is we use a cystotome, because that allows stability of the wire across. So we'll try for a minute or two. Otherwise, we will use a cystotome. Yeah? नीचे नहीं जा रहा है तो उधर से ला ना दूसरी तरफ से ला. Get it from the other side. So you see this wire is just not entering here. Yeah, इधर से हाँ या turn दूसरी तरफ yeah okay go into the other one if you can while being a sister. So what we will do is, since this wire is not easily going across, we will use a cystotome and then try to push. तो cystotome आ जाएगा ना इतने में. So I'm removing this needle now and I'm using a cystotome. ठीक है? निकालो. So we are removing the 19 gauge needle. Intermittent fluoro.
So Vinaya, are you going to use a 6' cystotome actually?
Yes. Yeah. Yes.
So now your plan is to perform hepatocogastro, or are you taking
no, I will
the
still try.
cystotome in order to play?
Yes.
Yeah. Okay, great.
I will still try to go antegrade.
And then would
I am literally old school here because I like transpapillary. So till the evidence is there that transduodenal or transgastric is, better, I continue using antegrade or rendezvous for my patients. So sparingly use CDS or HGS. It saves cost for my patients because the stents are cheaper. Fluoro.
Yeah, but I think that the anterograde is one of the most challenging procedures. So this is why we are with you today to try to learn everything from your expertise by
As I said, the only difficult part in this is passing the wire. So you saw that we are using a short Terimo.
Yeah.
And we used saline to push the last part of the wire in. So we have a 260 centimeters Terimo.
So this is another very important point because we are used to use the long one when we perform this kind of procedures.
Yes. This is very handy. The procedure becomes fast. Now, another important point for us is to, before we put in the accessories, to check the ultrasound, whether we are seeing the wire or not.
Yeah.
So right now I am not seeing the wire. See this? Now I am seeing the wire.
Yeah.
See this? That is very important because otherwise you lose your position and it becomes problematic.
Yeah, this is very important also when you push the devices to be sure that you are in the right position with the guide wire and the ultrasound machine, ultrasound probe.
So now I apply current. आना चाहिए नहीं दिख रहा है You see the cystotome?
Yes, perfect.
Yeah, so the cystotome has come out. I am again checking the wire and then applying current. I am in. Now it gives us little more stability to pass the wire across. So let us try. Let's hope that it works. Okay, pass. और पीछे आता हूँ थोड़ा पीछे से जाते हैं हाँ ये और पीछे आता हूँ हाँ अभी देख हाँ ये जो है ना नीचे हाँ ये नहीं वो छोटा सा काला है ना उधर डालना तेरे को टिप देख टिप उधर जाना चाहिए काले वाले में काले में नहीं जा रहा है हाँ इधर घुमा नहीं निकाल एडवांस करो So we keep changing the position of the cystotome to see if something works. Okay, good. You see, it went.
Yes, perfect. Perfect.
So now we go below. Now it should be easy because already there is a stent. So going into the duodenum is not difficult. So we are in the duodenum already. See this, I am past the stent. Now what we do is remove the magnification. Where? Huh. We inject contrast to see the duodenum, what is the position, and then change this Terimo into a stiff wire.
Which kind of wire are you planning to put to hold your stent?
So now we use the 035 wire. Inject. So, fluoro. Okay, so I think we are safe here.
Yeah.
We are in the duodenum, saline. Fine. Now let's go into place this wire, which wire are we using? Jaguar? Dream wire. So we are using the dream wire.
Still short wire.
No, now it is full wire.
Okay.
Now not short wire because we have to place the stent.
Yeah.
So we can place the stent on 260 also, but because there are so many angulations, if you see, Terimo wire will not be good because it will buckle. No. दूसरी तरफ जाना. Withdraw करूं? नहीं, withdraw करता हूँ. अभी देख. अभी जा.
And which kind of stent are you planning to put and which length?
So we will put, actually it's very funny. the patient's relatives want a covered stent. I usually put an uncovered stent, but they say no, the last covered stent fluoro. Upar dikhao. So they are insistent that it has to be a covered stent. So I am going to place a covered stent again. Anyway, the cystic duct is blocked, so I am not worried. But normally, I place an uncovered 6 or 8 centimeter stent. So the last step for this, okay. So it is important to know your angles. What are the angles at which the stent is likely to get stuck? Because when we push the stent into the biliary system, it automatically pushes our scope. And our scope should not be pushed too much back, otherwise you lose the position. So anticipate that there will be a problem where it is turning at the hilum, then where the tumor is there, and then of course finally when it crosses the papilla. In this case, papilla is already crossed by the previous stent, so I am hoping there will not be a problem. So hopefully the hilum will be the only place where we will probably have an issue. Okay, now let me first check the position again. Where is my wire? हाँ दिख रहा है, मेरे को नहीं दिख रहा है, दिखा? Okay, let us go in and see. So we are in. Now this is a problem. So here again, see my scope is going back. So I will ask Bibin to withdraw the wire a bit. Otherwise it will not turn. See, it's not turning. Thoda wire nikalo. Yeah, see he has withdrawn the wire. So it is turning a bit now.
Yeah, because you are using a stiff wire actually.
Yes, so here we couldn't have used a floppy wire. But everything is not still in our hands because it is really tight. Maybe I will have to dilate it. It's really tight. At all times, a good position maintenance is important. See, I'm putting a lot of pressure now, but it is just not advancing here. So this is the tumor which is giving us trouble. See? And my scope is getting pushed back too much. कितना जगह है? थोड़ा और निकाल ले. थोड़ा. Yeah. Little more. Now let us see. No. This will not go. I will need to dilate. Otherwise, this will not go. So you see, small issues. Normally, we don't need dilation once we are here. But sometimes the tumor is tight. And what is important is we should not lose the position. If you lose the position, see, I think I am a little, now this is okay. This is okay. Of course, I can deploy this stent here and it becomes a hepaticogastrostomy. There is no problem here. But I'm just trying to show you the problems that we face when we are doing a anterograde procedure. See, it's just not moving.
Yeah.
So you want me to?
I want you to perform the things that you perform at home. So.
Okay, so then we will dilate. I will remove the stent and we will dilate. Push the wire a little more. ऊपर दिखा ना? I'm withdrawing. So now we remove the stent again. नीचे दिखाओ. So at all times, keep the wire safe in position, because nothing works. You can even place a plastic stent. I have done a few of them. They all seem to work pretty fine.
Hello, Professor.
Again,
it's
check
Dario
the
from the
position,
audience.
whether your wire is nicely seen on ultrasound. Small amount of bile leaks you will see by the side of the liver. That is not to worry. It practically never causes a problem. Some of my Japanese friends also place a plastic stent once they have deployed the metal stent, which goes from the stomach into the bile duct. We don't use that because we haven't seen any significant bile leak happening after the stent is deployed. Most of our problems only happen if we are unsuccessful in the procedure.
Professor, is Dario from the audience. How do you...
Hi, Dario.
Hello. How do you decide the size of the balloon for dilation? On what basis, since you didn't have
So we normally use a 4mm balloon. Hurricane. Wire देखते रहना. You can also use a 10 French Sohendra. That is also fine because we already have a wire in. A 10 French Sohendra also works pretty fine. Little more cumbersome compared to the hurricane balloon. Has it come? Yeah. Okay. Dilate. So this is a hurricane, 4 mm hurricane. I am partly in the metal stent, so I'm a little worried whether it will burst. Okay, nice, very good. See, it has immediately opened up. You saw?
We saw perfectly that it dilated the stricture that you had very.
Yes. Deflate.
Really quick.
Little more inflate. I think we keep it for little more time. Inflate. Yeah. There is still one short angle there. We keep it for some more time. Okay, that should be enough. So you see that one area is angulated where the stent was getting stuck.
Yeah.
Should I? Wire rakho? So it is faster compared to using a Sohendra, using hurricane. Okay. And now we try to pass the stent again.
Great, we are with you.
Yeah. So yes, I know. I mean, by this time you could have done 2 CDS or maybe 2 HES.
No. It's
faster.
it's important.
But I like this procedure. I don't know. I love doing this. It is very challenging and mainly because I think my patient saves a lot of money.
Yes, but it's important to see all the procedures. So this.
Yeah, we do not have universal insurance in India, so a lot of our patients pay out of their pockets.
So we can imagine the costs actually.
So I am putting the stent again. You again check on the ultrasound whether the wire is in position. That is the most important at all times.
You also show very nicely that your scope is very stable and hasn't changed the position at all.
So we have gone easily now. we have a guide for where the papilla is. Otherwise, normally I inject here to see where the papilla is. Now here I know because of the stent that the papilla is here. So, नीचे दिखाओ. Okay, let us start deploying now. I'll pull it a little back. So we are only about 2 centimeters out from the previous stent. Okay. Yeah. Okay. So I think that completes the procedure. The last step is removing this. Sometimes it can be cumbersome.
Fantastic procedure. Fantastic procedure, Vinay.
Thank you.
So,
thank
you
very
much.
If you give me 5 minutes, I will show you the gallbladder drainage also. If you're busy somewhere else, I'll show it next.
Yeah, in the next, we will move and then we will back to you in a while. Thank you very much. Fantastic procedure.
Most welcome, most welcome, most welcome.
So now we move to the next case.
The next case is about a 79-year-old female patient with no remarkable family history who underwent in 2016 a right nephrectomy for a renal cell adenocarcinoma. She also suffered from chronic renal insufficiency and atrial fibrillation, in which, of course, the anticoagulant was adequately suspended. Recently, an apoechoic lesion of the pancreatic head was found during a follow-up abdominal ultrasound, and following abdomen MRI showed a 25 millimeters lesion of the pancreatic head with no contact with vessels and no dilation of the pancreatic duct. That findings was confirmed from FDG PET CT scan, and the blood tests were all normal, and so the CI 19.9. So today's procedure is US with FNA with rapid on-site evaluation, and the operators are Professor Dietrich and Professor Fusaroli.
Christoph?
Yeah. Hello.
Hello,
again.
Christoph.
We
Hello,
are happy
Pietro.
to present and to be together in a very expertise team. And our aim is finally to characterize that pancreatic lesion. So if I'm lost, I do not know where I am, what I have to do, I think about 33, 44, 55. 33 means go to the subcarinal region, turn to the left, turn to the right, and until I see the aorta and the heart. 44 means that I'm located at the 44 level, and turning left, turning right, and identifying the aorta. 55 means the bulb of the duodenum, which might be a different lecture. So we are orientated. When we have that ultrasound equipment like that, some people turn clockwise or counterclockwise, and it depends on orientation. So if we have the aorta in the center of the screen, we push the instrument from right to left to go to the fundus of the patient. And the other movement turns in direction to the pancreatic head. Why can I see the tail of the pancreas and the pancreatic head in one image? Because the pancreas is no sausage-shaped organ, but it's a U-formed organ which turns around my instrument. So that means by turning to the pancreatic head, and from the aorta to the left lateral position, upward is the tail. Okay, the first issue we are interested is that we also examine the highest stage of what we are going to see. And the highest staging is always distant metastasis, then lymph nodes, and then the original organ. So I'm interested to see the liver and to identify perhaps not seen metastatic lesion. Now, the next step is to improve image quality. And image quality means I put up the frequency, the dynamic range, and we have a quite nice image. And if we like to go deeper, then we also decrease the tissue harmonic imaging, and for higher, for more, let's say, focused image, we put tissue harmonic image in. And
so
then
the good thing in this regard, Christoph, is that we can save as many presets as we want in the modern ultrasound processors. So to change all these parameters, we don't have to go one by one, but we can also go preset to preset, according to your own preference, of course.
I love to understand what I'm doing, and
Yes.
I do not trust in presets. But you're totally right. If we are in a hurry,
preset made by you, not by Rolf.
Oh, thank you, Pedro.
Right now, perhaps you remind yesterday when I've been showing that cholangiofibroma, and those are von Mayenburg complexes, and they develop over time that you can see the cystic areas. And those lesions could be metastasis. Therefore, we should recognize also such small lesions and characterize and understand what they are from. So those are von Mayenburg complexes in a second stage, in the cystic stage, not in that hyperechoic stage where the ducts are such small that they have that bright echo. Okay, so our aim was to improve improve our image, and then I mentioned this is lateral and this is medial, and here we have that lesion, and what MRI might not have been described is what we have seen yesterday, the angioinvasion of that tumor. We recall oncological principle, renal cell carcinoma do infiltrate into vessels. Whenever we have a renal cell carcinoma, we have to look for renal vessels and inferior vena cava if they have been infiltrated. And here we quite nicely see that there is vessel infiltration, and I release a little bit of pressure, and then we can use the Doppler to delineate, and we can see it's not arterial, it's venous. Yeah, right now she's. I didn't ask that she would do respiration.
In the enthusiasm, the echo endoscope moved to the artery.
Thank you for that explanation.
The original was a vein. The original vessel was a vein.
Logical understanding of tumors, we have that circumscript infiltration of a portal venous branch, and which is typical for renal cell carcinoma metastasis metachronic. That could be 3 years, 5 years, 10 years, 15 years. And yeah, so then we are interested in that color. And if we go for color, we use the highest frequency, let's say, possible. We go for, if we look for sensitive, for a low wall filter, and we reduce our pulse repetition frequency to about 5. And at the very end, we increase, let's say, we increase our gain to get that lesion characterized.
Christoph?
Yeah.
Sorry to disturb you. Sorry. We need 5 minutes because Francesco and Michelle are deploying the Axios. So please wait for us another 5 minutes.
For all of us.
Thank you.
Thank you.
Go to room number 6. Michelle, Francesco.
We are going on with our boot camp GJ here.
Yeah.
As we can see,
could you resume what you have done?
Yes, so we realized that actually the Axios bounced against the loop of bowel, which means it opened in the peritoneum. But we were literally on top of a loop of bowel. So what we did, we removed the EOS scope. We went back down with the 2T scope, used the double channel from Fuji. And then Francisco grabbed the bowel that was facing the Axios while holding it with one of the channel. With a needle knife, he was able to create a fistula. And then he cannulated the fistula and placed a guide wire. He dilated 4 millimeter, that fistula, just to make sure that the Axios will go through. So basically, we're going to do bridging stent technique to basically secure the anastomosis. So what is he going to do now is over the wire that is into, can we see the fluoroscopy as well? Yeah. Here, he's going to advance the Axios. It's very important to keep holding the bowel because otherwise the bowel will escape. So the most important person in the room right now is the person holding the bowel with the biopsy forceps. So now, inside the large channel of the scope, because it's a double channel, he's advancing the Axios. So very important to use the 3.7 millimeter channel when you are doing this and keep the small channel for the biopsy forceps or the rat tooth. So you see very gentle now, he is advancing the Axios. Okay, our nurse is giving him a very nice tension, so he can advance. And while we're holding the bowel, to avoid that the bowel escape, he is gonna advance the Axios deep into the bowel.
Deep, hopefully.
Yes.
Look at this.
So, but the good news is here, you're not gonna lock the Axios. You're not gonna lock it. You're gonna let the first flange deploy into the bowel deep, okay? So at this stage, what he's gonna do, he's gonna start opening the first flange, okay? And let the first flange deploy itself into the bowel. We still have the wire as a safety net. Okay, let's deploy the first flange first. Okay. So he tried to advance just a little bit more the Axios, and now he's going to deploy the very first flange.
We have a loop there. That's why it's quite cumbersome.
Okay, so he's going to open the first flange, unlock the system here. Okay, good. And deploy the first flange. Let me help you with this. There we go. Yeah. Here it is. I'm going to hold you for this. Okay, good. All right, the first flange is deployed very deep. So now you need to bring back the whole system until you see the black marker. Pull, pull, pull. Okay, yeah, until you see the black marker. Do you feel the tension of the bowel here? You feel it?
Yes.
Okay, good. At this stage, what you're gonna do, you're gonna free the biopsy forceps. Free it. Yeah, open, yeah, abre. Okay. And what you're gonna do now, okay, remove it from the field. Remove the biopsy forceps from the field. Take it out. Okay, now, you're gonna deploy the second flange into the scope at this stage. So you're gonna stay where you are. It's locked, it has to be locked here. Yeah, the system has to be locked. Yeah, locked. Deploy the second flange into the scope. Go ahead, go ahead, go ahead. You're gonna back away with the scope gently, back away gently with the scope while you're doing this. Good, good. I'm gonna help you here. Here we go. Back away gently, back away gently, back away gently. There you go. Okay, here we go. So now you have what we call a bridging stent into the stent.
What's the size of the second
It's not gonna
axios?
migrate. Why? Because the first flange is fully deployed into the bowel, and it's protected by the first axios that we placed. That is the way to do a bridging stent when you do it with two axios.
Guys, before leaving you, first of all, congratulations. The second, two questions. The first one, are you going to clip this stent, this hot axios to the previous one? And the second is, are you going to dilate? Because if you look to the X-ray, it seems that the second, the proximal flange is not completely open at the moment.
So actually, Paolo, this two great questions. I'm gonna respond with the first one, the second one. We're gonna dilate. By dilating, two things gonna happen, okay? They're gonna approximate better the bowel to the stomach. That's number one. Number two is gonna allow us to decide if we feel safe or not suturing it or not, based on how well it is expanded and the relation between the two stents. So here in this case, we really need to dilate before making any decision. So can we have a 20-millimeter balloon, please, over the wire?
Okay.
Okay.
Could you show us the other part of the abdomen to check for the hair? Okay. The abdomen seems to be good.
Yeah, the abdomen seems to be good.
Please, could you show to the audience the diaphragm? More thorax, more thorax. Again, again.
And now come over here.
Yeah.
Something like this. Here you go.
That's fine. Fantastic, guys.
All righty.
Thank you very much. We move back to room number 5. Well done.
Thank you. Thank
Christoph, thank you for being so patient. Thank you very much with us. Okay.
Yeah, that was such exciting to see what happened with the axios and axios. Really great, great job. What we have been doing during that time, analyzing a little bit better also that there is angio invasion not only into a vein, but also into the artery surrounding. As you can see next to the arrow, we have that infiltration in the vein right on here, and we have that infiltration into surrounding arterial vessels right on here. What we are now doing is to inject contrast to see if that thrombus is appositional or if that thrombus is neoplastic. Is that right?
Correct. Before we go into the contrast, can you allow me to take main diameter of the main lesion, please? So we can catch a sense of what we can do afterwards. Okay. Yes. So main diameter is around 20 millimeters.
And if we go in the other direction, as you can see, it's 25 to up to 30. So
yes,
we have that longitudinal and that transverse.
So it's even larger than that.
It's even larger than that. But what is, how to say, our key message? MRI did not describe angio invasion, arterial and
venous.
So we are interested in how that works. That means we go for contrast harmonic imaging. And then we have different choices of different manufacturers. Wide band harmonic imaging or the amplitude modified, which is used for the transabdominal approach. And here we use the wideband pulse inversion mode.
Which gives us a realistic real-time impression of what's going on.
Okay, so let's count down 1,500, 1,400, okay, 5, 3, 2, 1, 0. Just give it. Very good, I love it.
So you want to start from the thrombus?
I will start from the thrombus because I'm interested if in the thrombus are arterial signals. That's the information I'm interested, and we can see it is like it is. There are arterial signals. It's a neoplastic thrombus.
This is an accumulation mode.
That was the accumulation mode. Whenever signals might be not such strong, I stop and give the machine the information. Yeah. Please give one image after the other to give me the best plasticity of the image.
Let's take a look at the main lesion.
So one more time, I will do, but I love also this one, because we are talking about aesthetic in endoscopic ultrasound, and that's really aesthetic. Okay, and now we look for the other lesion, and we can kindly see that this lesion shows arterial phase hyperenhancement, and even after 1 minute or something like that, the washout is not such strong. Do you agree?
For sure, completely. Yeah. So it's still very nicely enhanced. So
take-home message. Almost all ductal adenocarcinoma are hypovascular and therefore hypoenhancing. Almost all important differential diagnoses are isoenhancing or hyperenhancing in comparison to the surrounding pancreatic parenchyma, if that is not altered.
What we can say is that it would be very rare to see a pancreatic ductal adenocarcinoma which is enhanced in the venous phase.
Professor, can we use contrast enhancement? Do you think it has a role to look at the liver again and look for any eventual tiny metastasis not visible in the B mode?
That is to do the right thing with the wrong instrument, because I can't examine the entire liver, and I should do it transcutaneously. Second, we have a very high frequency, and the bubbles resonate at about 1.5. That means we have right now 5 or 10 megahertz. It's not the right way to examine the liver to exclude metastasis. We have seen the cystic elements in that von Meyenburg complexes, which is a B mode diagnosis. So there is, for me, no additional value. Would you comment on that?
Maybe you could use it if you saw something in B mode, then you can confirm with contrast. And of course, that would be an incomplete liver examination. Of course, if you explicitly state that in your report, it is fine. But you have to state that in your report that the liver examination was not complete.
Yeah, okay. Okay, now we will go for the FNB. It's an FNB needle Microtech 22. And we have been using yesterday also successfully, and hopefully we do it today again. That means we have to fix it right.
So while Christoph is lure locking the needle, he has to tip down a little bit the scope. So this makes easier to lure lock the needle. And we're sure we're not damaging the scope itself.
Pietro, what would be your strategy if you had identified hepatic lesions? Would you have started with sampling those lesions first?
Here we are outside.
Yes, but we didn't see any hepatic lesion in this case. Of course, if we saw a hepatic lesion.
If we saw a cystic lesion, and
yes,
for cystic lesion, we never do the contrast.
We don't need to sample the.
Never examine a cystic lesion by contrast if you do not see any nodule you'd like to judge perfused or not perfused. So we got that image.
Endoscope.
Just checking
your
needle trajectory is safe.
Somewhat safe.
I know your needle will come out from the left.
That's totally true.
Like in the UK.
Mute kar do.
You want to withdraw the stylet a little?
Yeah, sure, I will.
Okay, so now the needle is exposed by withdrawing the stylet, and you see it's gone through the lesion very nicely.
So we can pull a little bit. No. Okay, that's fine. Nothing else. And now, let's say with certain, it's a pretty soft lesion. As I mentioned yesterday, whenever we examine such a lesion, I always try to test if the feasibility of my methods are working. So sometimes I also use the elastography for certain guidance. And the movements I do a little bit to the right, a little bit to the left. We do not apply any suction because it's highly vascularized. Relax everything and try to see if we have enough.
Christoph, Pietro?
Yes.
Thank you very much. It was fantastic demonstration. We wait for the final diagnosis, and then we can move to Mumbai back because I see. Thank you very much again, guys.
Thank you.
Vinay, can you hear me? Vinay, can you hear me? Vinay, can you hear me? I see you, but I can't hear you.
Just give me 1 minute.
Okay, great, great. We see you perfectly.
Audio, please. Let us check the audio.
And hear you perfectly. Everything is okay. You can present your second case.
Can you hear me now?
Yes, perfectly.
Perfect. So this is the same case, Paolo. I told you that there is a massive gallbladder distension. So I am in the gallbladder. I am in the duodenum looking at the gallbladder. And I'm finding the position a bit difficult because of all the anatomical issues here. You see there are large lymph nodes. So I slowly start coming back and see whether I can get a nice position. This is just coming to one edge of my scope. See here? And then I withdraw, gently withdraw, and it disappears. It's a very big gallbladder. So I'll see if I can get a good view from the stomach.
When you want to drain the gallbladder, is your first target the duodenum usually?
Yes, always, always. But here, I'm finding it much closer to the stomach. I think it is very distended. Yeah. Also, I'm seeing a little bit of free fluid here, if you can, very minor, but there is free fluid between the gallbladder.
Yes, we can appreciate.
Yeah, very small amount. Yes, here. See this?
Yeah.
This is free fluid. Here. Yeah. So, I think this looks like a good position. Let us check endoscopically also once. Endoscope, please. So, I am here in the antrum now. Yeah, this is the antrum and this is the gallbladder. Fluoro, let us check the fluoro position also. Okay. Can we turn her flat? Or actually, let it be like this. Let it be, let it be. Let it be. We'll do it in left lateral only. So this is the gallbladder, you see, massively distended. Let's try to place a stent here. We'll use a 15 mm Axios. Can I get the Axios, please?
Which size do you choose usually?
I normally use a 15 mm. So 20 only for GJ.
Yes.
Rest everything 15 and bile duct 10. These stents are excellent stents, as you all know, made our lives very easy. थोड़ा cautery का position change करना पड़ेगा. So I have preloaded this stent with a wire. It's a 025 Visiglide. Should we start? Are we ready? So let us see what is the position now. It's a little odd position to me. Normally I don't work in this position. Then let us see how it goes. Okay. Give me a Doppler once. शीत की वजह से हाँ नहीं ठीक है कोई मेजर वेसल नहीं है. So I'm going to puncture now. Why we don't like to go from the stomach is because once the gallbladder collapses, it withdraws from the stomach wall. So we are in. Now we will pass the wire.
Do you always use the wire to perform the gallbladder drainage?
Yes, I prefer to place a wire. Basically, it protects. I mean, there is no data for that, but we believe it protects the opposite gallbladder wall from injury.
So then
there's no data for this.
So then you have scheduled to put something inside the hot axis or double pigtail stent or something like that?
Yes.
Yeah.
Yes. Okay. Now let us pull it a bit. It's just like pseudocyst.
Yeah. And you
so
prefer
it's now tenting well. Fluoro, has it opened well? Let me pull a little more. This looks good. And now we deploy the stent.
Can we have the endoscopic view?
Endoscopic view, please.
Yeah.
Great. Yeah, you see the black mark?
Yes, yes, we see. Thank you.
So we slowly withdraw this. Slowly withdraw the scope and push the whole thing out. It's going in. See that? To be careful that it doesn't go in. So turn it clockwise. Okay. So it's a mucocele. You can see?
Yes.
There's a lot of mucus that we are draining from here. Now we will withdraw this assembly and just place a double pigtail stent. You can see the fluoro picture. Are you seeing the fluoro picture?
Yes.
Yeah, so the stent is nicely deployed. We will withdraw the assembly now. Okay. I was expecting a gush actually, but there is no gush. That means this is all thick mucus. Nikalu?
Do you always place a double pigtail stent?
Yes, yes. In gallbladder, yes. Our most common indication for us is acute cholecystitis, and I'm really worried that if this stent hits the opposite wall, it may create trauma. So I like to place a double pigtail stent usually through this. A short stent, not a very big stent. So we are using a 7 French double pigtail stent. What is the length, Vibin? 5 centimeters. So it's a small stent. The procedure is exactly like what we do for our PFC drainage. Now slowly you can see a lot of mucus is coming out. It doesn't look infected to me. Yeah, middle one. Okay. Since this patient, the intent is palliative and there is unlikelihood, practically no likelihood of this patient going for surgery, I think this stent will be kept indefinitely, limited lifespan. So I think this will help drain the gallbladder. Where is it? Okay, deploy. Deploy किया? इतना देर? हाँ, निकाल. Now the last part. See, it is again going in. So you have to prevent it from deploy कर दो. Okay. So this is done. Great. I have a pancreatic duct drainage also with me in case you have time.
We wait for you. If you
just give me 5 minutes.
Ready, we can show that.
Okay, just give me 5 minutes. I think.
Okay, we go back in 5 minutes.
Yeah.
Thank you, Vinay. See you.
Most
so now
welcome,
we can go back to room number 5. Christoph, can you hear me?
Sorry, yes.
Yeah, great. So what about your FNB? So do you have the adequacy?
We have been 2 times punctured and still waiting if we have enough and good material, and then we will proceed or take out the instrument for the moment. But the puncture was quite well performed, and we are waiting for the result.
Do you usually have the rows in your department, or do you perform the MOs or BOs or whatever it is called?
Yeah. In the past, I had during certain times rows in my department, but nowadays I'm working in a department finally only going for histology, that means FNB, and a second to put that material into formalin, avoiding cytology in most cases. So that's pretty similar to what Anand Sahai explains us on how we do it. Keep it short and simple. Even he does not use contrast. We agree on that very simple, let's say, way on performing biopsy and histology.
For sure.
You agree?
Yeah, I do. I have my mic. Sorry, Paolo, you took us by surprise.
Okay. Don't worry.
I thought you were not coming back, so I am.
You should be always ready with us, you know.
I am guilty. I took
what we have been discussing right now, if you still see the image, I'm not sure.
Yeah, I see the freezed image.
Yeah, we have been using fine flow for better delineation of small vessels, and we have been interested to see that this thrombus is, how to say, within a certain vascular structure to identify the flow within that portal venous vessel. And this is well shown here as an advantage of that high sensitive way on discriminating vessels compared to the conventional color Doppler imaging and power Doppler imaging.
Shall we show this in real time?
Yeah, love it.
So Davide Caddeo is with us and is kindly helping us with this fine setting.
So what I do is always, I'm looking for the lesion, never using color. I get dizzy by that additional information. And then we have put the lesion in the center, and then we come a little closer, look high frequency, high dynamic range, the right sound speed, and then we look quite nicely under real-time conditions. Don't breathe, don't move, don't breathe, don't move. No, that is not depending from us. But here we can pretty nicely delineate. Even we can see an arterial vessel by using fine flow at this location. So that's really very good resolution and demonstrating the advantage of such a super sensitive Doppler function.
And also, Christoph, I'd like to emphasize you are using a very high magnification range here.
Yes.
So you are using the power of US to its maximum. You have increased the view of the lesion of interest. We are using a 2 centimeter range here, if you see the scale to our right. So I always like this way of working. Don't go with such small images. Sometimes I see EUS being performed from far away, like looking with a wide angle.
So thank you guys for this explanation. I move to Professor Doglioni room in order to see whether you have been able to obtain the adequacy with your FNB.
Yes,
thank
now
you very much.
The
Thank
material,
you, Claudio.
The material is good now and is consistent with a metastasis of renal cell carcinoma. Usually when we have renal cell carcinoma metastasis to the pancreas, we obtain fragment like this. In this case, you see some hyperchromatic nuclei, and usually it is difficult from this picture to see which is the composition of the tumor, but because there are several vessels inside and also the neoplastic cell. But this is the picture that we see with the renal cell, clear cell carcinoma metastasis to the pancreas.
Okay, thank you very much, Claudio. Usually this is a very difficult diagnosis by cytology because of the blood and so on.
Yes.
Can you comment on the fact that probably with the Vivascope, because you avoid the blood, could be a better option in this case?
In this case, in case like this, yes, is a good option because we see only the parenchymal structure, not obscured by the blood. And also on this material, you can perform also some immunohistochemical marker in order to confirm the renal origin of the tumor. And because sometimes there is the differential diagnosis between neuroendocrine tumor versus renal cell carcinoma metastasis, and this is useful to have tissue for immunohistochemical studies.
So thank you very much, Claudio. It was a perfect diagnosis. I see that Christoph is already there, but has completed the procedure. So we can move to room number 7 and present the case, and then we will move to Mumbai.
The next case is a 62-year-old male with a previous cholecystectomy in the last May. The last month, an uncovered SAM was placed during ERSP for jaundice in a locally advanced pancreatic adenocarcinoma. For concomitant gastric outlet obstruction, he performed an abdominal X-ray with gastrography, which showed a type 3 duodenal stenosis. At the blood exams, a slight elevated directed bilirubin with cholestasis was showed. Today's procedures is US-guided gastroenterostomy. Operators are Professor Seti and Professor Teiberg.
Hello, I'm Rita. Good morning. Hello, Hemi.
Morning.
Can you hear me?
Yeah, we can hear you.
So great to have you both in the same room together with Livia and Delfina. So quite completely women in the endoscopy unit today. So I'll give you 2 or 3 minutes just to show the first part of your examination. Then we will move to Mumbai and then back to you.
Yeah.
Thank you very much.
Thank you so much, Paolo. And I have to say, thanks for being brave to let us try another EOSG day. Excited to be here with this team. So this is a little bit different from the other cases in that the obstruction is more distal. And I have inserted an upper scope, and we had already injected and tried the wire and found that we could not, we can't reach the area of obstruction with this scope. So one of the things, Flora, that we're going to try to do, inflate the balloon, please, to 18, is just try to see if we can kind of pressure inject a little bit to help define and inject here. Because if this is very tight, the wire was really not going through, the mucosa is also extremely friable. And so one of the things that we might need to do is actually take this scope out and put a pediatric colonoscope in to try to get a little bit closer to the actual area of obstruction so we can manipulate the wire through the stricture. Because the last thing we want to do is blindly try to advance and go through tumor or anything like this. So just trying to see, you can see it's very tight. We're really not getting any contrast through there. I'm having a little difficulty advancing the wire. Okay, balloon down. And of course, the issue will be also to make sure that we are able to find a loop. First of all, advance the actual naso catheter through that tightest stricture, and then ultimately find and identify a loop of bowel that is distal enough. So I switched my wire to a glide wire. Just to see if we could help manipulate a little. And I'm controlling the wire, which I know hasn't traditionally been done here. Can you flush for me? I'm having a little resistance to the wire going down. So we're gonna just play with this a little bit more. And like I said, if we really have a lot of difficulty, we'll throw a pediatric colonoscope down to try to visualize a little bit more of the stricture, because you can see it's much more distal than where we are right now.
Amrita?
Yeah.
As I told you, we moved to Mumbai for a while, so in order to let you play with the guide wire and manage the stricture. So thank you very much.
Yeah.
Since now, and then we moved to Mumbai. Vinay?
Laura?
Vinay? Can you hear me? Vinay? I see your case, but I cannot hear you. Vinay? Vinay, can you hear me? We see the case. It seems to be a very interesting case. Planned rendezvous, main pancreatic duct stent placement for pancreatic duct stricture. So we're waiting for you guys. Yeah. I see somebody moving the arrow on the PowerPoint, but we cannot hear you. So I see the case, MRCP in 2022. So if we are not already, we can move back to room number 7. So we move back to room number 7. So Amrita?
Yep.
We are back because we have some connection problem with Mumbai.
Okay.
So we are with you. So
Okay, so
it's
we
interesting
inject-
seeing you playing in
Great.
and managing the stricture.
This is the hardest part of the procedure. Is
Yeah.
actually getting across the.
And so what I've done is I've actually taken the wire out. I'm going to succumb to letting somebody else control it as we were finding a little bit of resistance. But actually what happened is when we injected contrast, you can see it under pressure, it did open up a little bit and we were able to advance some more. So we're just reloading the wire.
Hello.
Hello?
Hello.
Sounds like India might be trying to connect.
Amrita, I think that they are ready. So
Okay, sounds good.
Sorry for
Hi,
going
Amrita.
in and
Hi,
out.
Vinay
your
from
room.
Bombay.
Thank you
Can
very
you hear
much.
me?
Okay, Vinay, we can
Paolo,
hear you now.
am I on?
No,
Can
you
see me?
are
Can
you
hear
are
me?
on. Thank you. You are on.
Okay, okay.
Great.
So this is a case of chronic calcific pancreatitis, stented before, has a stricture, tight stricture in the genu. Somebody has tried an ERCP outside and could not pass the wire across the stricture. So he sent the patient to us. So we will try a EOS rendezvous. Can we turn the patient flat? So you can see a dilated pancreatic duct here. It's about 4 or 5 millimeters. We will measure it. So I like to do all these procedures in a supine position. You see this dilated pancreatic duct here. So we have to get a good position first. Here, Doppler. Okay, so this is the pancreatic duct we should aim for. Okay.
Vinay, do you usually attempt for a rendezvous as a first target? And in case you fail, do you usually put a pancreatico-gastro? Is that your schedule today?
Yes.
So your first is rendezvous. Your first idea, scheduled procedure.
As I told you in antegrade, my preference is always a transpapillary stent placement. If that fails, then only we go for other procedures.
Yeah, it's interesting because yesterday, Schalk van der Merwe from Leuven did the same as you are planning now. So he tried to perform a rendezvous technique, and then at the end, unfortunately, he had to put a pancreatic
Yeah,
gastro.
in the end, if it doesn't succeed, then we have to go for pancreatogastrostomy. So I'm just using the 19 gauge needle. This is a Boston Scientific. I like it in pancreas because it is sharper, little sharper. So let's get our position again to see what is happening. So this is the duct in the body. Now I turn a little anti-clockwise. You can see stones here. Lots of stones. And then I like the genu as the first point. If we have a dilated duct there, we need a longish segment to puncture. Then only it succeeds well. Otherwise, it becomes problematic, the puncture part of it. So I have a very good position. Now I am not so sure. Okay. There are lots of stones here. So this is one area where I can puncture. Fluoro. I always like to see on fluoro what is the position of my scope. The scope is too straight, so passing the wire will be a bit difficult. So always for the younger crowd, spend some time on these things. What is a good position? Where are you likely to get the best results? And then take out your needle a bit, Doppler once again.
Do you mind and do you fear the fact to having stones very close to the tract of your needle?
Yes, it can create technical problems, but if there is no solution, then we go for it. very frankly speaking, I am not happy with this site. And I think I may turn the patient back to left lateral because I was getting a better view from the left lateral. So after the puncture, we will see whether we need to shift back to
your first target,
flat.
as
Yes.
you said, is the PD at the genus. Because
I love
it's more
PD at the genu if I can get a long view.
Great.
So better to spend some time on it rather than, you know, puncture and then have problems later on. So I'm looking for a.
That's a very important suggestion, really, very important suggestion for the young endosonographers.
Yeah.
And here we have a lot. So we are very happy about that.
And there are lots of stones, you see here. And I'm trying to find the dilated, right? Yeah, I think we are now in business. See this? This is a duct which is going across down here. See, this is the duct that we should puncture.
Yeah,
this is a better
that's
duct.
a good position, yeah, really.
This is a much better duct.
Yeah.
So let's thoda magnify aur kar do. Yeah. Now let us see whether our needle is in position for this or is it going by the side. Very often, especially in pancreatic duct, you may just go parallel to it and you are not in the duct. So, and pancreas is fibrotic. So you have to be really forceful. It may not just go through. See, it is a very fibrotic pancreas. So I've gone through. Now I am in. Can we inject?
Which needle are you using?
I'm using Boston Scientific 19 gauge. Okay. So we are in the duct. Saline. You saw the fluoro picture? We are in the duct.
Yes, we saw it very well.
And we are seeing a dilated pancreatic duct. Nothing is going ahead.
Can we have the
fluoro? Inject. Okay. So now to turn this patient flat is going to be troublesome. So I will try this angle only and see. We'll use a Terimo here. Terimo. I am not very happy again with the needle position, but we will see how it goes.
Is this a long wire?
No, short wire. We love all the short wires. इसको पकड़ना नहीं, इधर ही जाएगा, नीचे जाएगा. It's very important, as you all know, communication in the team should be constant and they should be clear what is expected and what they should do. So, fluoro, we are in the right track. Slowly go. Either, jao. Yes, slowly go. No. Ahead. You need to go ahead. Yeah. See, it's going. Nice. किधर जा रहे? So we are, I think, right at the stricture. See, on ultrasound, if you see, you can see the needle withdraw karo. Okay. So we try, like for antegrade, we try for a little time. If it doesn't work, then we use a cystotome. So we keep the wire here and use a cystotome.
We can see in the echographic view that you are perfectly inside the
That's very important.
Yeah.
Always.
And you keep the position very straight. This is a very important.
नहीं नहीं अभी गया था ना नीचे हाँ ये देख अल्ट्रासाउंड में दिख रहा है ना ये देख फ्लोरो धीरे धीरे हाँ हाँ ये है so this path I think we have to take and we do not have much leeway here.
Probably with the cystotome you could have a much more leverage to play with the guidewire. Yeah.
So there is a tight narrowing, I think. And नहीं square shear हो जाएगा. हाँ ये है. This is the way. This is the way we have to go. Yes. Very good. Go ahead. Very nice. Very nice. So Bibin is doing a great job, as you can see. I think we are almost beyond the stricture now. धीरे धीरे ऊपर देखते रहा कर रहा टिप घुमा हाँ वो नीडल के पास में मुड़ रहा है ना वो नहीं मुड़ना चाहिए. So we are discussing among ourselves what is the best route to take, but I think he is on the right track. Little bit of luck and we should be in the duodenum. अच्छा था अभी क्या हो गया हाँ घुमाने का पैपिला की तरफ ये देखिए duodenum है ना हाँ ये very nice.
I think that this is a fantastic demonstration of the teamwork in US guided therapeutic procedure.
Yes.
You had a fantastic discussion in between the team.
Yeah, we always communicate with between ourselves, and Bibin always gives me suggestions and I listen to him very often. The other people in the room also are very देखना अभी गड़बड़ हो रहा है.
It's a fantastic experience.
We are almost till the papilla. We need just one more push and we should be through.
Yeah. And
so these are, for me, these are like challenges. I enjoy them. And I hope audience is also enjoying this challenging conditions.
We always love that.
Always consider pancreatic duct more challenging than bile duct. The chances of failure are higher.
Probably this is the most challenging US guided procedure, therapeutic procedure. And the most risky as well.
Laura?
Do you consider the possibility to, now that you are very deep into the PD, to change from the needle to the cystotome?
Yes, I think we are probably going to do that. Because it is stuck at one point. It is just not going. Coil कर दे, cystotome ले लेते.
What kind of guide wire do you recommend?
This is a Terimo 032, Terimo, 260 centimeters. You can see on the fluoro that we are very close to the duodenum, but somehow we are not able to go into it. So what you do, we will take a risk and try to change the position of the patient so that we get a better idea of what is going on. Dhire dhire. But then we'll know whether we are stuck at the accessory papilla or the main papilla, what is going on. That thing is not clear. Very slowly. This looks good. Now you see the anatomy is much clearer. Once we turn the patient supine, Laura, somehow it is not coming out of the duodenum. Okay, we are through. You saw?
Yeah, perfectly.
We are in the
Congratulations, fantastic.
Okay, now I withdraw this needle and use a cystotome.
Now you put the cystotome in any case.
अच्छे से दिखा यार, मजा नहीं आ रहा है. Like that. Should I withdraw? Okay. Wait. I have lost the wire on the wire. nahi. See, I have lost the wire on the ultrasound. I'm trying to find it. It's extremely crucial. Okay. निकालो. ठीक है? So, as you mentioned, Paolo, very concerted effort. So, we keep checking with each other.
We are very happy.
Now he's using water, so I'm doing it very fast. So we are out.
This is the
now
most
I'm
difficult
worried
part
about
with
my
the,
position.
With a short wire, it's very difficult to do this, to be able to remove everything. Yeah. But we are very happy because yesterday we had pancreatic gastro and today we have a rendezvous. It's fantastic.
Ready? Wire. आ नहीं रहे. Shear हो गया. So the wire is giving us resistance. I'm taking it out. So while exchanging, I'm trying to put the cystotome. The cystotome is not going very smoothly on the wire. So these are the problems with the short wire exchange. Sometimes you are not happy with what's happening. चालू करो. क्या करूं? नहीं जा रहे. नहीं जा रहे. So I will have to withdraw the needle, the cystotome again. So he's pushing saline. Check करो क्या problem है. Flush करो अच्छे से. So this is a very hydrophilic wire. And that is a thing. If there is not enough fluid, it just doesn't go forward. Flora? कौन सा वाला है? जी फ्लेक्स है कि दूसरा है? अभी गया. We are stuck. Sometimes the wire gets, because we used it with the needle, there is some slight shear in the wire and then cystotome doesn't go over it. निकालूं? So technical issue. We'll pull the wire and little stuck. The wire is stuck. Now it has come out. So we're pulling the wire a bit. बहुत tight. Claro? अभी देखो ये सब देखो गीला नहीं है. See, this is पानी नहीं है इसमें. So we withdrew the wire a bit. And now wetting the Terimo again. ये मैग्निफिकेशन कम कर सकते हैं मेरे ख्याल से. नहीं तो ठीक है. नहीं ठीक है. Let's hope. So I think the wire has got. अभी देखो. Wire is somewhere. The covering has torn off because of the needle. We used a very sharp needle. So we are not able to push this above. It just doesn't go. Flora? So now we are in a soup because we are across the duodenum. I think what we will do is we will remove this Nicolo and we remove the EUS scope and put the ERCP scope. Nicolo?
You plan to leave the guide wire or try to leave the guide wire in this position?
Yeah, it's a little difficult because it's a Terimo wire. I don't like.
Yeah, because it's short wire probably.
Yeah, but we will try like that and we'll use the ERCP scope. Okay, all ready? Fluoro. This wire seems to have created problems. It's not going. नहीं किधर बीच में अटका है मेरे ख्याल से. अभी देखो निकालो धीरे धीरे. अभी ठीक है. फ्लोरो निकालो धीरे धीरे. It's getting stuck. So we are doing it a very slow thing because somewhere I think has lost sheath. चलो निकालो. थोड़ा ही नहीं ऐसा ही जा रहा है वो. तो धीरे धीरे निकालने का. So this step takes about 2 minutes, but you see because we are hamstrung, the wire is going in very slowly. So somewhere it has created धीरे.
So now you plan to go with the duodenoscope over the guide wire, or you go in another position? So you plan to reach the papilla with the duodenoscope, leaving the guide wire?
Yes. धीरे both. Now see, very little wire is left in the duodenum and I am very worried. इसको पानी लगाओ. That if it comes back into the papilla, we are back to square one. पानी लगाओ और इसमें भी पानी डालो. So we are using liberal water. डालो कोई बात नहीं. Okay. Very difficult.
Yeah, I can imagine.
Very difficult. Okay, थोड़ा देखो जाता है क्या? Very little remaining. धीरे धीरे एकदम धीरे. We should have probably coiled little more of the wire in the duodenum. Thinking. कितना बचा है? We are at okay, last 20. Very slow. Totally stuck. बेटा खुला हुआ है. नहीं. कर धीरे धीरे कर बेटा.
Siamo persi.
We are stuck. Stop, 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 stop. और पानी डाल.
Loro sono pronti.
The last 20 centimeters, I hope.
Vinay? Vinay? Can you hear me? Vinay, can you hear me?
Can't hear us.
Vinay, can
I
you
can hear you.
Yes, please. Thank you. While you are playing to remove the instrument, we present another case, and whenever you are ready, we will back to you. Okay?
The following case is a man of 69-year-old that for recent onset of epigastric pain and weight loss, 3 kilograms in 3 months, underwent abdominal CT scan that show lesion of the isthmus head of the pancreas associated with marked hypertrophy of the pancreas upstream and vascular infiltration of splenic portal confluence. Blood test showed a CA 90.9 of 4,835 with normal cholestasis index. Today's procedure is EOS-guided FNA with rapid on-site evaluation performed by Professor Saftoiu from Bucharest and Professor Sahai from Montreal.
Adrian, can you hear me?
Can you hear us?
Yes.
Okay.
Yes.
Hello. So
Hello, guys.
Together with Anand.
Hello, Anand.
Really. We
Great.
have a nice team assembled here. So we started already the examination. We are using Fuji film scope. It's the EG 58. Yeah, and it's a 3.8 millimeter channel. So it's a conventional scope from Fuji with the same Arieta 850 system. So you can really see nicely the resolution of the image. And we started imaging. So the scope is in the stomach. And we will get rid of we are not interested in the endoscopic image anymore. So we sucked all the air out. So we are at the level of the pancreatic body, and you already, Anand is showing you. This is not normal. It's a really big mass in the middle of the screen. So now we can characterize it a bit. So it's hypoechoic. It's really inhomogeneous. You see that it might have some necrotic part here in the middle, but we will probably see that better with contrast. And then we can look, we've measured it, it's about 5.5 centimeters and 4 centimeters. So it's really a large mass. Huge. Of the pancreatic body. And then, of course, you can use Doppler. So you nicely see the splenic artery. So when we're going to do the final aspiration biopsy, we have to take care of the splenic artery. If I torque a bit the scope, now we're trying to image the, I'll try to get to the confluence. We had a very nice image where maybe here you can see that there is
He has some ascites.
Yeah, he has some a small bit of fluid there.
That's also not good.
And also it has invasion of the confluence. You can see that there is no flow and there are a lot of collaterals surrounding the tumor. So basically we will try to avoid those collaterals as well during the FNA.
from color Doppler, we can switch to eFlow. The ultrasound system is set up a bit different than the other ones, so you don't see it bidirectional here. But anyway, you nicely see the flow in the splenic artery.
What's the advantage of eFlow?
The advantage of eFlow is that it works with low velocity, low volume blood flow. So it depicts fine vessels. But here you can see that you see very well the splenic artery. You don't see much inside of the mass. So you guess already that the mass might be hypovascular. Of course, we need to enhance that with contrast, but this mass is probably hypovascular. Then we can characterize it. But now you see the invasion of the, and you nicely see with us. Yeah, that's encasement. So you see tumor tissue here. You see tumor tissue on the other side. That means that the vein is 360 degrees involved. So it's a complete encasement of the vein here. So that's why you see tumor tissue here as well and here as well. So that's why the collateral circulation and the cavernoma that was described on CT. So of course we can work further. We can do elastography, but of course this shows you that it's hard. So we even don't need to measure this.
There's a lot of green though.
Yeah, but whenever you're in doubt, if it's green and blue, so you need to leave the transducer free like this.
It's still staying very green.
Now I'll show you. We can freeze the image. Now you might say it's in between green or blue.
It's green here.
Yeah, I agree with you, but try a different thing. If you don't believe,
work on it till it gets blue. Is that what you're saying?
no. If you don't believe your own eyes, because you cannot differentiate so many shades of blue and green, just try a strain histogram. So you do a strain histogram. So you do a measurement here in the tumor. So it's pretty easy, like this, and then you do a strain histogram. You see that the average value is towards the blue.
Okay.
So it's very. I mean, if you're not sure of your own eyes, just do a quantitative measurement, and then it will be
the objective measurement. So that's good. Yeah.
Yeah. So with the strain histogram, it's pretty easy because you use only one region of interest, which here is it's a box. It's not a circle, but anyway, it's a box.
The completely black color is also quite reliable.
Yes. I agree with you, maybe, but maybe there's a necrotic part. So
well, there's definitely something.
Yeah.
In the middle here.
Here we'll get rid of the elastography, but I will still do a contrast just to guide the FNA. Of course, wait.
If the contrast comes out saying this is not necrotic, you would put the needle here.
Let's.
I would never put the needle.
Yeah,
no
but
it
will not be. You will see. It will not going to enhance here.
But if you know it's not going to enhance, why are you going to do it?
I'm not sure. Are you sure it's necrotic?
I'm sure that's necrotic. It's a big black hole.
Yeah, maybe.
In the middle of a tumor, for sure it's necrotic.
Not. Yeah.
I mean, what else could it be?
Anyway, we will target the periphery of the mass.
For sure.
That's the to get rid of the splenic artery. We will target here most probably. Leave the necrotic part. If you look at the contrast studies used for FNA, the data is contradictory. So I wouldn't rely too much on that.
Adrian?
Yes?
Anand? We move back to Mumbai for 2 minutes and then back to you.
We will set the contrast.
Thank you.
Yeah, thank you.
Vinay? Vinay, can you hear me? Vinay? I can't hear you. Can you hear me? You have to... You must unmute on Zoom because you have muted Zoom. Can you hear me? Can you hear me now?
What has happened is...
Okay, great.
With the ERCP, and you can see the duct here. And there is a very tight stricture. We could not keep the wire in place because... So I thought, let me try directly ERCP. And I hope we should be through. It's a tight stricture. You see here at the neck. Okay. Okay, now see. Yeah. Wow. The problem, problem area. It's really tight, really tight. गर्म हो गया. Okay, now see. Looking गड़बड़.
Collateral. Seems to be a collateral.
Yeah. Very tight stricture there,
Yeah.
very tight. I think थोड़ा सा contrast inject करो. You will know where exactly we are, what is magnify करो. धीरे धीरे हाँ बहुत सारा don't inject too much contrast. देखते हैं ना. फ्लोरो इंजेक्ट दिख रहा है. We are not seeing any duct properly. It's all coming back, so I think it's a total block.
Yeah.
So it's a challenging case.
Yeah,
we had
it
the
is,
wire
it is.
nicely out, but because it got stuck in the scope, and we used the 19 gauge needle. I think that caused a little shear. It happens off the wire within the scope.
Yeah.
Also, he has many stones, so it's.
Would the ESWL help here if it's a mixed problem? ESWL, if it's also stones that may block the passage and not only the stricture, could that help?
Yeah, in the end, if nothing works, probably I will go in with a spy scope and try to at least, pulverize the larger stones inside.
Can you hear me?
Yes.
Can you hear me? We move back here in Milan while you are playing with the PD. Thank you. Bye now.
Okay.
So
Okay.
we can move.
Thank you very much, Paulo. Thank you.
No, you're welcome. We will wait for you to see whether you have been able to pass.
Okay, I will tell you.
Thank you.
Yeah.
So we move to Adrian. Can you hear me?
Yes. Can you hear us?
Yeah, I can hear you. I'm hearing you very bad, but you can go. You are ready to perform the contrast.
The contrast.
Great.
To explain a
Go
bit,
ahead.
that we set up the system is very nicely set up. So what we want to see is the grayscale information in the left panel and the contrast information in the right panel. And actually, we don't want to see in the right panel. We want to see only some small shadows where the hyperechoic elements are on the left side. So we don't want to see anything in the left panel except the microbubbles. Then we expect the splenic arteries here. Somewhere the splenic vein is here. So I'll try to keep both of them like this, and then we can inject, and we expect the contrast showing up here. So yeah, please. So we're injecting the sonoview, and I'll start the counter, so you can see the counter. So now it's about 3, 4, 5 seconds. So you should wait for 10, 15 seconds, and now you see the contrast in the splenic artery nicely, but you don't see it in the tumor. So then we can increase a bit the gain maybe, and look also, you nicely see the splenic artery, you nicely see some collaterals, you see some just a bit of vascular elements here and there, but nothing much in the tumor. Now I'll try to torque a bit. We don't see much in the splenic vein either, which is quite profound here. That's I think that's the SMA down here.
So you can see that it works up to 5 centimeters. And I'm looking more at the tumor, and you see it has some signals. So the idea would be to target those regions where we see some scant signals like this ones. In the other parts of the tumor, we don't see anything. So most of it is probably necrotic. What we can do to enhance the signals is to use the accumulation mode. So we just press like this, and then you see there are tiny vessel signals here and there. So I'll try again. Keep it. You have to keep it very still. So it's not much, actually, not much signal in the tumor. What you can see sometime is you can also help you stage properly. So you look at the hypoechoic infiltrations on both sides of the artery. Of course, here is the splenic artery, but you can see the tumor is here, and that there is the wall here of the artery. So this might also be involved as well. Here you see as well, it might be tumor tissue here as well.
On the other side of the artery?
Yeah, sometimes you can see that very nicely.
Are there any data to actually support that?
No, but I think there are not too many studies comparing contrast with CT.
Right.
With contrast enhanced CT. There's not much signal.
I just would find
actually.
it surprising to have the tumor is here and to have tumor encasement all the way on the other side.
It might be there as well.
Full.
It might be there as well. But there aren't too many signals, so you can see it here and there. And now we are at more than 2 minutes, so we still have contrast. So what you can actually do, we can go back. I'll try to switch let me see, to switch the contrast. So you see now the contrast also very nice spontaneously in the splenic artery. Now if we push the Doppler again, you see that even with contrast, we don't see signals inside the mass. So a lot of it is actually most probably either hypovascular or necrotic.
Hypovascular for sure.
Yeah.
I think the necrosis is really in the center.
Yeah. So I think now you can see better the encasement of the splenomesenteric confluence. So down here. Yeah,
so as a rule, if you want to see there's vascular involvement, try and trace the vessel completely. And if you can't trace it, then there's a problem.
Yeah.
And it's also very suspicious when vessels change diameter in a strange place.
But here you can see it. It's completely. It's completely. I mean, there's.
It's not easy to see, but if you really make the effort to try and get a long view of the vessel, and you really can't get a long view, they suggest that there's vascular involvement.
And you see there might be a small ascites here.
Yeah.
We saw that before.
Yeah.
So I think we can go to FNB.
FNB.
Yeah,
Okay.
we can.
Needle.
So we're using a Charcot. Is it a 22? I think 22. Yeah. Okay.
So I think there's general consensus that for FNB, the 25 gauge needle is just not really doing the job to get good cores. And it's the 22 is pretty much just as easy to use, but gives you better cores. And then the 19 is just, it's basically people use it only for liver, I think. And 22, I think, is pretty much what everybody's using for solid tumors now.
Okay, so we just, you can nicely see here. So you see I'll get rid of the Doppler because you can see that the splenic artery is a bit far away. You see the sheet here, and then you see also the needle coming out. So the needle is this one. So it should be okay, I guess, here.
There's definitely ascites.
Yeah, there is ascites there. And it's important to see it before the puncture, because then if you are seeing it after the puncture, then you might think that might be bleeding. But this should be a straightforward puncture. So usually we'll do a slow pull, although I don't think we need. Do you think we need the suction here, Anand, or slow
Certainly
pull
not.
or whatever?
And,
I mean,
and the slow
we
pull
will
is a complete waste of time.
exactly. So we will get tissue without those, I guess.
Yeah.
So I completely agree. We can change a bit the angle.
I think
just
it
do
is
a
good to really go though as far as you can, really long strokes, and then to come out and go over somewhere else. We like to come out of the tumor and really fan
another region,
completely different
like
areas.
this.
Yeah. Because now you're basically going in the same area all the time.
Yeah, no, I think we can do it without. We'll get a
so we come out, we move over, we go here, we come out, we move over, we go here.
I'll switch to different parts of the lesion. So I think we will get nice course. I mean, usually with the shark core and
the shark core is amazing.
With the Acquire as well, and with the Microtech. So all FNB needles are
I think they're pretty
game
much
changer.
Yeah, there's no data showing one is better than the other.
And you have to twist your scope. You see that you can move your body slowly, and we are interested to see the tip of the needle always. So sometimes the needle goes on the left or on the right side, so you just move a bit just to see where the tip is. That's important to do it. But I think we can see what we have. How many passes would you do, Anand?
Well, we use moles, so if I look at the sample and I have white cores, then I stop.
Then you stop.
But even if I see white cores, often I'll do just one more, just why not?
Okay.
But I just say that's the advantage of using no suction, is that you get less blood, so you can see the cores much better.
Exactly.
So Anand.
Yes.
And Adrian, thank you very much for this demonstration of the fanning technique and discussion about the stylet or no stylet, slow pull or no slow pull. Everybody, I think, has his own experience, has his own idea is what better as compared to the other. Thank you very much. So I think that we can close this morning session while there are also other rooms that are working. So people, I think, that can go to have some lunch, but we will all go online in the auditorium with the case that Amrita is still practicing to prepare for the gastroenteroanastomosis. So back at 2 o'clock, please.